Okay, I see the screen better now. Hopefully, again, you don't have any difficulties right now. So you don't have any difficulty, right? So I don't know. It's my personal difficulty, which I felt, which was quite distracting for quite some time. So you don't have any problem, right? Are you guys able to see? Thank you so much. Okay. So, I mean, this is a kind of a restart. I don't know, but sorry for that. So, actually, we have been discussing about inflammatory bowel disease for quite some time. So, just I'm writing the important points that we have been discussing. So, when it comes to the risk factors, number one, this is the first thing we have been discussing. So, uh, especially we have discussed on smoking and appendicectomy as a risk factor for developing ulcerative colitis and Crohn's disease. As I told you, even though the association is not that great, but still, there are some controversial studies. But nevertheless, at least for our competitive exam's sake, we need to know that appendicectomy and smoking do increase the risk of development of Crohn's disease, whereas for ulcerative colitis, they are associated with reduced risk. Even though the strength of association is quite controversial, but nevertheless, you need to know this point. Apart from that, the second thing where we discussed is on the pathophysiological aspects. As far as the pathophysiological aspects are concerned, we initially talked about the HLA association. So in that, we know that HLA-DR2 is being linked to the development of ulcerative colitis, and HLA-DR1 and HLA-A2 has been linked with the development of Crohn's disease. And that too, I specifically stressed on the point that these HLA associations do increase the risk of development of extra-intestinal manifestation of Crohn's disease than compared to the intestinal manifestations of Crohn's disease. Then we talked about what kind of T helper pathway that's actually associated with the development of ulcerative colitis and Crohn's disease. We know that T helper 2 pathway is the one that is very important as far as the development of ulcerative colitis is concerned, whereas the T helper 1 pathway and to an extent the T helper 17 pathway is very important for the development of Crohn's disease. And we also have discussed that we have the undifferentiated T cell, which can differentiate into a T helper 1 pathway, or probably a T helper 17 pathway, or we have T helper 2 pathway, or it can differentiate into something called as a T helper, T regulatory pathway. We have discussed all these things in detail in rheumatology section itself, T regulatory cell pathway. So whenever you have a kind of Crohn's disease like picture, the T helper 1 pathway and to an extent T helper 17 pathway is going to be very important. We also know that T helper 1 pathway is the one that is classically responsible for the production of granulomas. So you have studied that as well in rheumatology. And the classic signature cytokines of T helper 1 pathway are going to be the tumor necrosis factor alpha and interferon gamma. We discussed that already. And the classic signature cytokines of T helper 17 pathway, which means those are secreted by T helper 17 cells, include interleukin 17. And further, they are also going to secrete something called interleukin 23. So these are going to be the cytokines that are very, very important for the development of Crohn's disease. So that is the final take-home point. That's what we need to know as well. So that's going to be the reason for telling the next one. So the genetic polymorphisms you're talking about. As I told you, the interleukin 10 polymorphisms are very, very important for development of ulcerative colitis, even though again the association is a little low, but still they increase the risk of development of ulcerative colitis. I told you these polymorphisms are studied in something called genome-wide study, so GWS. That's where they studied this genetic polymorphisms and association of a particular disease in the population. And if you ask about Crohn's disease, again, we also saw this, that interleukin 23 receptor polymorphisms are actually considered to be protective, and they reduce the risk of development of Crohn's disease, to be honest. So that is the point that is very important. As I told you, the interleukin 23 does play a very important role in the development of Crohn's disease. So if you have a receptor polymorphisms and poor functioning of the receptor, you might have a reduced severity or probably even a reduced risk, and can be considered protective against the development of Crohn's disease. As we discussed, there are some genes that are associated with the development of Crohn's disease. So we can actually split into a kind of two. So we have discussed on the NOD2, CARD15 protein mutation. So there are two kinds of pathways. For example, the innate immunity pathway mutations that can affect the development of like this inflammatory bowel disease, especially Crohn's disease, or it could be something called as an autophagy pathway that can also be involved in the development of Crohn's disease. For example, if we talk about innate immunity, you have this typical IBD1 gene. So this is what we have discussed. IBD1 gene, which is actually present on chromosome number 16, that's going to produce a protein called as NOD2, or otherwise referred to as CARD15. So NOD2 CARD15 protein. So this is the point that is going to be really, really important. And it's been asked multiple times in any exam for that matter. What is the gene and what is the protein that's been associated with the development of Crohn's disease? And apart from that, it's been suggested that this PTPN28, which is associated with most of the, autoimmune disorders as well as inflammatory diseases. So PTPN22, protein tyrosine phosphatase, and 22. So this is also linked to the development of inflammatory bowel disease, especially Crohn's disease, but not ulcerative colitis, which we'll be talking about that. As far as the autophagy pathway is concerned, we have something called as the ATG gene, and we also have the IRGM genes, which are linked to the development of Crohn's disease as well. But the most important of all is going to be the NOD2 CARD15 mutations, which are very important because NOD2 CARD15 is linked to the development of mucosal immunity against certain bacterial components. And if that is defective, then certain bacteria can enter the intestinal wall and go into the submucosal and then into the vascular segments of the intestinal wall, and they can increase the immunity against the gut. So, form of an autoimmunity that can result in the development of chronic inflammation and granulomas. So, and defects in NOD2, that is loss of function mutation of NOD2, will definitely upregulate something called as NF-kappa B pathways, and that is also going to be a key reason for the development of inflammation in these patients. So nevertheless, so this is the loss of function mutation of IBD1 gene, that is NOD2 CARD15 protein, is the one that is associated with the earlier development of Crohn's disease, especially this ileocecal Crohn's disease. That's what is going to be at high, these patients are going to be at high risk. And when it comes to ulcerative colitis, it's going to be the epithelial barrier genes that's going to be important for the development of ulcerative colitis. As we have discussed already, there are quite a few number of genes, even though the association is quite questionable. We have something called OCTN2 gene mutations. Then we have CDH1, which we have discussed already. Then we have something called HNF4 alpha. And we also have something called as LAMP1. So these are the genes that's been suggested to be playing a role in the development of ulcerative colitis. But on the other hand, you have certain genes like NOD2, you have certain genes like PTPN22, we have certain genes like ATG, which we have discussed already, which are not associated with the development of ulcerative colitis. Even some studies tell that, this NOD2 mutations and PTPN22 mutations actually reduce the risk of development of ulcerative colitis. But this is again questionable, only like told by certain books and certain studies, but nevertheless, this is highly questionable. But at least you need to know that these are not related to the development of ulcerative colitis. In fact, as a whole, if you want to know, innate and autophagy mutations are associated with Crohn's disease, and epithelial barrier gene mutations are basically associated with the development of something called as ulcerative colitis. But these mutations are there. This is called IRGM mutations. This can be associated with the development of both ulcerative colitis as well as Crohn's disease. IRGM mutations are associated with the development of both ulcerative colitis as well as Crohn's disease. Fine. So we leave that. So, but nevertheless, so I don't know whether they will ask you this many details or not, apart from your DM gastroenterology NEET SS exams. Apart from that, I don't think, like they're going to ask these many details. When you talk about your NEET PG exam or probably INA-CET, it's going to be this, that's going to be the question, almost always, if they wanted to ask in this area. Now, apart from that, there are some genetic syndromes that are associated with the development of IBD or probably an IBD-like picture. So that's what we're going to see next. Is there any syndromic relationship with the development of IBD or IBD-like picture? So, in this, there is no much differentiation between whether it's a Crohn's disease or ulcerative colitis, but we are going to consider this spectrum as a whole, IBD-like or probably IBD picture. Number one, the most important is Turner syndrome. I think in the premium lectures we have discussed on Turner syndrome, in that I had mentioned about certain patients of Turner syndrome get GI symptoms, especially those that mimic inflammatory bowel disease, if you remember. And we have something called as Szymanski-Pudlak syndrome. So if somebody wants to know what Turner syndrome is, I don't want to discuss in detail. It's a monosomy X, but we have multiple different genetic variations within Turner syndrome. And one of the most important organ systems that is affected in Turner syndrome is the reproductive organs, which means they will be having gonadal dysgenesis, a sort of streak gonads. That's what we here. I mean, you can call gonadal dysgenesis. Probably we can call it a streak gonads because of that they'll be infertile. Remember, Turner syndrome is a syndrome of females, and apart from that, they can have plus or minus cardiovascular defects, like especially left-sided defects like bicuspid aortic valve and coarctation of aorta. But the most common problem is going to be the transverse aortic arch. And apart from that, many of the individuals will be a growth retardation. This is considered to be the characteristic triad of Turner syndrome. So streak gonads causing infertility and primary amenorrhea, followed by cardiovascular defects, and most of the individuals will be having growth retardation. Apart from that, they have eye problems, ocular problems, psychiatric problems. But one good thing is there won't be any kind of mental retardation in patients with Turner syndrome as a whole, except with one particular variation which might have mental retardation. Apart from that, usually you don't get mental retardation in patients with Turner syndrome. When you come to Hymansky-Pudlak syndrome, we know it's an autosomal recessive disorder, but you can't ask the same with Turner syndrome because Turner syndrome is a chromosomal problem and it is not a inherited problem. So you can't comment whether it's an autosomal recessive or dominant as far as Turner syndrome is concerned because it's a chromosomal disorder or it's a chromosomal aberration. So what is the characteristic feature of Hymansky-Pudlak syndrome? You can remember a kind of a triad, or probably a sort of a triad. So usually they will have this albinism, or probably you can call it as oculocutaneous albinism, which means it will involve the body as well as the eyes. That's what we call oculocutaneous albinism. And they do have this bleeding diathesis. So especially because of platelet dysfunction, especially there will be disorder of platelet aggregation, and because of that they might be having bleeding diatheses. And the third thing is the pulmonary fibrosis that these patients tend to have. Very rare syndrome, but one of the associations in this syndrome is the IBD-like picture. Apart from that, there are certain glycogen storage disorders, especially disorders like von Gierke disease. Even though there are quite few evidences to tell it has association with other glycogen storage disorders as well, but only strong association that's been proven is the von Gierke disease that has good association with the development of inflammatory bowel disease like syndrome. And we have the classic Wiskott-Aldrich syndrome due to the mutation of VASP defect. So it's an X-linked recessive disorder. The VASP gene is the one that will be defective here. That's present on the X chromosome. The patients will be having immunodeficiency, the patient will be having bleeding diathesis. At the same time, the patient might be having eczema, chronic eczema. So these are very characteristic features of Wiskott-Aldrich syndrome, and we don't want to discuss in detail about that. And finally, we have something called IPEX, immune polyneuropathy X-linked, where the patient will be classically having neonatal IBD-like picture. So we have discussed that already, I guess. The classical features of IPEX is the mutation of FOXP3 gene. FOXP3 gene mutations will result in dysregulated or probably underdeveloped T regulatory cells. Because of that, the immunity will be overwhelmed, and they will classically develop that neonatal diabetes mellitus along with neonatal diarrhea and malabsorption. And the picture will be usually IBD-like, especially more of a ulcerative colitis like compared to the Crohn's disease like picture, and we have seen that in detail in the endocrinology section itself. So I don't want to discuss much about that. So these are the 5 important syndromes that have IBD-like association or probably IBD-like picture. So one is the Turner syndrome, second is Hymansky-Pudlak, von Gierke, Wiskott-Aldrich, and IPEX. The details of all the syndromes I've told you, and I think most of the syndromes you would have heard, but one thing you would not have heard is Hymansky-Pudlak. That is the reason why I told you what are the characteristic features of Hymansky-Pudlak syndrome. So with this, let us move on to the next set of pathophysiology. Is there any relationship to infection and the development of inflammatory bowel disease? Actually, answer is yes currently, but previously it's thought it's not really related to infection as much. But the idea why it's related to infection, so why we need to believe that this inflammatory bowel disease can be related to infection, because if you see the bacterial content is maximum in the stools. If you see in the stools, the bacterial content is maximum in the terminal ileum and then in the colon. which is actually the area that is involved by IBD. In fact, the colon is the one that is primarily involved in patients with ulcerative colitis, and terminal ileum is the one that is more commonly involved in patients with Crohn's disease. And these are the areas that are typically involved in IBD, and these are the places where you have the maximal bacterial content as well. The flora is maximally located in the terminal ileum and the colon only. Almost 10 to the power of 12 bacterium per ml is located in this particular area. So probably, definitely, that because there are more bacteria, I'm not telling that is the reason for development of IBD, but there is something that tell that bacteria and its relationship with the inflammatory bowel disease. That's why I told you that point. Maximum number of bacteria seen in the terminal ileum and the colon, which corresponds to the area that is typically involved in patients with inflammatory bowel disease. So that must be some association. So then, as far as the Crohn's disease is concerned, there is one important bacterium that is called as actually John's bacillus. This is quite a few number of times a question in exam. So that is called as Mycobacterium paratuberculosis. Second called as Mycobacterium paratuberculosis. Quite a few number of times they have been asking this question. Even I think the last time they asked this in 2014. Before that they asked in 2010. After that you didn't get this question much, but still it's a point that's worth noting. So John's bacillus or Mycobacterium paratuberculosis is being considered to be having a good association with the development of Crohn's disease. And then there are quite a few number of organisms like chlamydia, even though the association is questionable and poor, but still it's been suggested. Listeria. Then we have Pseudomonas, especially there is a particular type of Pseudomonas called as cell wall deficient Pseudomonas. And we have certain strains of E. coli, and it's been suggested to be having association with certain species of Clostridium as well. So these are some of the bacteria that's probably associated with the development of IBD. But one thing that is 100% definitely associated with IBD is John's bacillus, that is Mycobacterium paratuberculosis. That's supposed to be having a definitive association with the development of Crohn's disease, because this John's bacillus is something that is really seen in cattle, and they cause a kind of intestinal disease in cattle that is very strikingly similar to IBD. So that is the first time they understood that this could be having association with human inflammatory bowel disease as well. And many patients with inflammatory bowel disease, especially Crohn's disease, did show a positive culture to Mycobacterium paratuberculosis, which is actually an organism that should be seen in the cattle. So probably how this is transmitted to human, and there is no clear-cut epidemiological relationship between eating their milk or meat. So, but we don't know the clear link between how it's transmitted or how it's acquired to humans. But nevertheless, it's been suggested that this organism has been related to the development of Crohn's disease, that is IBD. And then there are quite a few number of evidences to say so that IBD is related to development. Infections related to the development of IBD. For example, we have some antibodies against certain bacterial components. Like for example, we have something called anti-OMPC, that is called as outer membrane protein C. This is a this is a protein that is found on the E. coli wall, outer membrane, and that antibody is found in many of the patients with inflammatory bowel disease. And second, we have anti-I2 antibody, so which is actually against some of the components of Pseudomonas, especially the cell wall deficient Pseudomonas. And we also have something called anti-CBARL, that's called CBIL. So this is an antibody against flagellin of Clostridium species. So which means this is an antibody against E. coli, this is an antibody against some of the components of Pseudomonas, this is an antibody against the flagellin component of Clostridial species. So these are the evidences to say that you have some substantial association with infection and the development of inflammatory bowel disease, and they do have some good association. They are having better correlation with Crohn's disease compared to that of ulcerative colitis. Remember, I'm not telling that not all patients with inflammatory bowel disease will be having association infection. Not all patients with IBD will be having association with Mycobacterium paratuberculosis. But quite a few patients do show some relationship between infection and development of inflammatory bowel disease. So, usually when you talk about this kind of autoimmune disorders, you think about a multifactorial relationship or a multifactorial association. You cannot pinpoint one particular thing to the development of autoimmune disorders, but it's a kind of multifactorial thing. So that's what you need to know. So which means this could be one of the relationships or one of the associations for the development of inflammatory bowel disease. So as far as the antibodies are concerned, I told you they are having much better correlation with Crohn's disease compared to that of ulcerative colitis. Again, I'm not telling that these antibodies, they will be always present in patients with Crohn's disease. Means if they are present, they predict very high severity. In the sense like there are patients who do have these antibodies, but if they have, they tend to have extremely high severity, especially they're going to have increased risk of development of severe strictures and fistulas, which are very characteristic features of Crohn's disease. Strictures and fistulas are something you don't see in patients with ulcerative colitis, but you do see in patients with Crohn's disease. So there is an extremely high risk of development of strictures and fistulas if you have these antibodies, and it correlates with severe Crohn's disease. That is the point that we need to know. And apart from that, this anti-OMPC antibody and anti-CBARL antibody has been shown to be associated with something called as pouchitis as well. Clear? In patients with ulcerative colitis. So these antibodies, all three are associated with high risk of development of strictures and fistulas in patients with Crohn's disease. At the same time, anti-OMPC and anti-CBRL has been associated with high risk of development of something called as pouchitis, which is very common in patients with ulcerative colitis. After you do a surgery called ileal pouch anal anastomosis for patients with ulcerative colitis, that's actually a curative surgery for ulcerative colitis. But even though it's performed later, that's considered to be curative for patients with ulcerative colitis. So once you do that IPAA, you create a pouch kind of appearance, so they can result in development of pouchitis. And these antibodies are having a higher correlation in the development of pouchitis in patients with ulcerative colitis who have gone for that ileal pouch anal anastomosis surgery. So now we have discussed on the pathophysiology. Now going on to the actual pathology. So what you're going to see in patients with Crohn's disease and ulcerative colitis. So that is the third difference. So let us talk about the sites first. So what are the sites where you're going to see Crohn's disease and ulcerative colitis? I'm not talking about the most common site, but the overall sites where it can affect the Crohn's disease part. So when you consider a Crohn's disease, so it can affect anywhere from mouth to the anus, which means entire GIT can be involved in patients with the development of Crohn's disease, which means anywhere in the GIT from mouth up till the anus, you can have involvement in patients with Crohn's disease. But as far as the ulcerative colitis is concerned, you're going to involve only the colon. So we can be very clear, even though, you can have something called as a backwash ileitis. So that's a different terminology, but the only area that will be involved in patients with ulcerative colitis is going to be the colon. That's all, as simple as that. Nothing else will be involved in patients with ulcerative colitis. So that is the reason why it's suggested that ulcerative colitis is basically a curative disease, whereas Crohn's is something that is not curative because it can affect any portion of the GIT. But ulcerative colitis, since it affects only the colon, if you remove that colon, in the sense like when you do a colectomy, for example, a total colectomy, this disease is actually curable. But Crohn's disease is something that can be controlled but cannot be cured. So which means Crohn's disease is not curative. You cannot remove the entire GIT and replace the entire GIT with something else. So that's why Crohn's disease is basically not curative, but it is controllable with current therapy, because we have serious immunosuppression that can control the progression and the severity of Crohn's disease. But when it comes to ulcerative colitis, it's considered to be curative. Suppose, for example, if you do a total colectomy, it's a curable disease. So that's the first point that you need to know. And of course, now comes the most common site. When you talk about the most common site, the terminal ileum is going to be the most common site. But remember, ileocecal is the most common area that is involved in patients with Crohn's disease, in the sense like isolated small intestine, that is terminal ileum alone, that is small intestine only, is quite rare. So what I'm trying to tell is, even though textbooks tell terminal ileum is the most common site that is involved in patients with Crohn's disease, yes, that's correct. I'm not telling without terminal ileal involvement, it's very rare to have Crohn's disease, very commonly involved in patients with Crohn's disease. But if you take the most common overall association, it's actually the ileocecal area that is actually quite involved in patients with Crohn's disease rather than the terminal ileum alone. So in both these conditions, in both these terminologies which I told you, terminal ileum will be involved. It's not like terminal ileum is not involved. Terminal ileum is the overall most common site in patients with Crohn's disease to have the involvement in the GIT. But if you ask the most common, to be honest, it's going to be the ileocecal that's going to be the most common compared to the terminal ileum alone, which is actually quite not common compared to the ileocecal disease. So ileocecal disease is the most common, or you can call it as ileocolonic, whatever may be the case. So that's going to be the most common site that is affected in patients with Crohn's disease. When you talk about the ulcerative colitis, it's always the rectosigmoid. Even though people talk about rectum being the most common site, but it's rectum not, I'm similar to Crohn's disease. Rectum alone is quite less commonly involved compared to rectosigmoid, which means then followed by the rectum alone, which means rectal involvement alone is quite rare. So most of the times you're going to have involvement of rectosigmoid as a whole, which means rectum is invariably involved. I'm not denying that fact. Similarly, terminal ileum is very commonly involved in patients, Crohn's disease. I'm not denying that fact. But when you talk about really the most common site that is affected, you need to consider that as a whole. Rectosigmoid is the most common in patients with ulcerative colitis, and ileocecal or ileocolonic is the most common in patients with Crohn's disease. Then you talk about rectal involvement. So then we talk about the sites, then we talk about the rectal involvement. Rectal involvement is invariable in patients with ulcerative colitis. Invariable in the sense it will be 100% there in patients with ulcerative colitis. Without rectal involvement, you can't get ulcerative colitis. But I told you, if you really want to know the theory, the most common site is rectosigmoid, but rectal involvement is invariably there. I'm not denying that fact. But here, rectal involvement is absent. You don't have rectal involvement in patients with Crohn's disease. That is one major difference between the differentiation of Crohn's disease and ulcerative colitis as far as the colonoscopy findings are concerned. The number 3, ileal involvement. We talk about, as I told you, especially the terminal ileum. Ileal involvement, especially the terminal ileal involvement is what we're talking about. Again, it's invariable, almost invariable in patients with Crohn's disease. Almost 95 to 100% of all patients with Crohn's disease will have terminal ileal involvement, but here it is typically absent. Please understand there is something called as backwash ileitis that can happen in patients with ulcerative colitis. That is due to leakage of the colonic contents through the ileocecal valve in a retrograde fashion into the ileum that can cause a kind of local inflammation in patients with ulcerative colitis, which we call it as backwash ileitis. But actually the disease does not involve the terminal ileum. It only involves the colon, but because the inflammatory substance that comes from the colon back into the terminal ileum from the colon, that can result in something called backwash ileitis, which means the disease does not directly involve the terminal ileum. Very rarely, because of this inflammatory backwash into the terminal ileum, you can get that backwash ileitis, but that is different from actual ileal involvement. Ileal involvement is characteristically absent in patients with ulcerative colitis. And then coming to the nature of the lesion, so whether it is the entire intestinal wall that is affected or only the mucosal part which is affected. So let us see. So what's going to be the nature of the lesion in patients with Crohn's disease? In Crohn's disease, you're going to have something called as a transmural involvement, which we have been discussing for long. And I think every single pathology as well as surgical teacher will be discussing about the transmural involvement, which is a full thickness, wall-to-wall involvement. You know what I mean by transmural. We have studied that in cardiology, myocardial infarction chapter itself. And most of the time, you will have a superficial involvement in patients with ulcerative colitis, very characteristic, which means you're going to involve only the mucosa as well as and the submucosa. So these are the only areas that are involved in patients with ulcerative colitis, superficial involvement. At the same time, even though it is full thickness, transmural involvement in patients with Crohn's disease, there will be discontinuous involvement in the sense like there will be a lot of skip lesions in patients with Crohn's disease, which are very characteristic. You would have studied that already. And when you talk about this ulcerative colitis, it will be more of continuous lesions. More of a continuous lesions in patients with ulcerative colitis. And coming to the ulcers are supposed to be deep because of the transmural involvement, which typically produce sometimes a cobblestone kind of an appearance. It's called as a cobblestone mucosa. This is a keyword that's very commonly associated with Crohn's disease than ulcerative colitis. And when you talk about ulcerative colitis, The ulcers are supposed to be more superficial in nature. We'll be talking about how these ulcers are called. Sometimes they're called as collar button ulcers, which we'll be talking about in some time. I'll show you the images as well. Then comes to the microscopy. Coming to the microscopy part. So what is the characteristic feature of Crohn's disease? We have discussed that already in the beginning of the chapter itself, that the granulomas, especially the non-casseting granulomas, are very characteristic features of Crohn's disease. So I'm going to write that only. So non-casseting granulomas, very characteristic hallmark of Crohn's disease in the intestinal wall. Usually this non-casseting granuloma, these lymphoid aggregates tend to be transmural, as we had discussed already. It's going to span the full thickness of the intestinal wall. That's again a very characteristic feature of Crohn's disease. Rarely you might see cryptapsis. Students might think that cryptapsis means it's a feature of ulcerative colitis only. No. So the presence or absence of granulomas, that's going to tell you whether it's a Crohn's disease or ulcerative colitis. Cryptapsis may be seen if colon is involved. Remember, colon involvement in patients with Crohn's disease is quite common. As I told you, ileocolonic disease is the most common thing to happen in patients with Crohn's disease, but they won't have rectal involvement. That's the key point. So if colon is involved, you can get cryptapsis also, like similar kind of ulcerative colitis, but it's the granulomas that's going to differentiate your Crohn's disease from that of ulcerative colitis. Usually, because you have a skip lesion in patients with Crohn's disease, so usually you have a kind of a local inflammation in a particular area and a background normal mucosa, which means there will be a surrounding normal mucosa and a focal background inflammation is a very, very characteristic feature. And in that area, you will see that granulomas, lymphoid aggregates and all these things. So there will be a focally enhanced inflammation with a normal background is a very, very characteristic features of Crohn's disease. And to be honest, the dysplastic changes is quite rare. In fact, it doesn't happen in patients with Crohn's disease, which means the cancer risk is quite low. But whereas in ulcerative colitis, the dysplastic changes will be quite common, which means the cancer risk is going to be quite high. So what are the characteristic features? First, the most important thing to note is no granulomas, as I told you. This is going to be the most important point. No granulomas in patients with ulcerative colitis. And most of the time, the involvement will be very superficial and won't be transmural, which means the characteristic involvement will be something called as cryptitis, plus or minus formation of crypt abscess without granulomas is very characteristic of ulcerative colitis. In a sense, like this cryptitis will lead to something called as crypt distortion. Crypt distortion. So what do you mean by crypt distortion? The crypt architecture will be distorted. That's what you call as crypt distortion. And these are very classical features of ulcerative colitis. And remember, there will be a focal inflammation, as I told you. There will be a focally enhanced inflammation even in patients with ulcerative colitis. But the thing is, the background also will be inflamed severely, which means the background will not be normal here. So there will be a surrounding background inflammation along with the focally enhanced inflammation, which is very characteristic feature of ulcerative colitis. As I told you, for patients with Crohn's disease, you have focally enhanced inflammation with a normal surrounding background most of the times, but in patients with ulcerative colitis, there will be focally enhanced inflammation with a background inflammation as well, typically made of a chronic inflammatory infiltrate. So which means there is no skip areas. You can remember like that. It's more of a continuous lesion. And dysplasia is quite common. Dysplasia is quite common in patients with ulcerative colitis. And that is the reason why they are more prone for development of colon cancer as well. One of the important risk factors for development of colon cancer is a background ulcerative colitis, not Crohn's disease. And there are something called as inflammatory pseudopolyps. These are polyps that are going to arise out of inflammation, inflammatory pseudopolyps. Usually, like they are rare. As far as the exam sake is concerned, you can tell they are not seen in patients with Crohn's disease, but generally they are rare. They can be seen, especially in terminal ileum. If at all they happen, they can happen in terminal ileum, but they are quite rare to happen in patients with Crohn's disease. If you talk about ulcerative colitis, they are quite common. One of the regular features of ulcerative colitis in endoscopy, in colonoscopy. Typically, you will see the pseudopolyps in the colon. Clear? And they'll be more diffuse in nature. In the sense, in Crohn's disease, it will be more patchy, located only in the terminal ileum. But whereas in ulcerative colitis patients, they are very common and they're more diffuse in the sense like throughout the colon, you will be seeing And the risk of development of this pseudo polyps is more in patients who are having pancolitis, the entire colon involvement. So when you talk about, I mean, pancolitis generally has more severity, which means pancolitis means the entire colon is involved. It's going to have more severity, and they're associated with more of backwash ileitis, more risk of development of cancer, more risk of development of this pseudo polyps, and all these things are having higher risk of development in patients with pancolitis. Generally, pancolitis is more severe, but pancolitis is also associated with higher risk of development of backwash ileitis, inflammatory pseudo polyps, as well as higher risk of development of dysplasia and colon cancer. These are things that you need to know. Then I think we have finished on the pathology. Now we are moving on to the clinical features of Crohn's disease versus ulcerative colitis. So we are going to split into two, intestinal features, and second one is the extraintestinal features. So that's how we are going to split into. So first, the intestinal features. Intestinal features. As far as the intestinal features are concerned, for example, Crohn's disease is associated with more of a abdominal pain, abdominal lump, especially right iliac fossa mass, strictures, perforation, fistulas. So these are more in favor of Crohn's disease, but tenesmus, rectal bleeding, bleeding PR are more in favor of ulcerative colitis. Let us see one by one. So when you talk about abdominal pain is extremely common in patients with Crohn's disease because strictures are quite common because there'll be a kind of subacute obstruction that will be going on forever. So that is the reason why abdominal pain is quite common, especially this abdominal pain will be more of colic in nature and typically will be located in the right iliac fossa region. And it's one of the most common symptom in patients with Crohn's disease. If they ask you most common symptom, it's always abdominal pain, the most common symptom in patients with Crohn's disease. It's quite rare. I can tell maybe plus or minus, but as far as the exam sake is concerned, it's rare. You don't get it in patients with ulcerative colitis. Then what about mass? Abdominal mass. Once again, it's quite common in patients with Crohn's disease, especially RAF mass, because terminal ileum, strictures, dilatation, all these things are common. So it's commonly a mass-like appearance that you see in the terminal ileum. That's quite common. Here it's quite rare. You don't get any mass-like lesion here. And abdominal tenderness, and this again will be in the right iliac fossa, which is the terminal ileal region. It's quite common. It's quite rare in patients with ulcerative colitis. And apart from that, you have rectal bleeding and tenesmus or bleeding PR, tenesmus, which is quite rare in patients with Crohn's disease, but it's extremely common. One of the important presenting features of patients with Crohn's disease, ulcerative colitis. Apart from that, both these individuals can have diarrhea, both these individuals can have altered bowel habits. Remember, usually in Crohn's disease, initially they will have diarrhea. Later on, once they develop strictures, they go for constipation. Abdominal pain is a very important feature. Because initially they tend to have diarrhea, then they go for constipation. Once they develop constipation, it means the strictures are very severe. They're causing a subacute obstruction. That's what it means. And as far as ulcerative colitis is concerned, usually the most important feature will be diarrhea. Typically, that will be associated with bleeding PR. So that's a very common feature of ulcerative colitis. And if you talk about constitutional symptoms, that fever, malaise, anorexia, so this cannot separate these two disorders, and it's going to be seen in both these conditions: fever, malaise, anorexia, little bit of weight loss, common in both. Clear? And similarly, there is a considerable myth with regards to aphthous ulcers that is seen only in patients with Crohn's disease, even though this can be true for exams, but there are multiple studies which tell that are quite common in patients with ulcerative colitis as well, which means it's not like you get aphthous ulcers, especially oral aphthous ulcers, only in patients with Crohn's disease. Even though for exams this holds true, oral aphthous ulcers are very, very common in Crohn's disease, but in reality, when you take the trials as such, it's a feature of ulcerative colitis as well, which means aphthous ulcers are a feature of IBD, not Crohn's disease or ulcerative colitis alone, even though it has a slightly high risk of developing with more intensity and more severity in patients with Crohn's disease and more early in patients with Crohn's disease compared to patients with ulcerative colitis. So in exam, maybe you can go for Crohn's disease, but overall, aphthous ulcers are a feature of IBD as a whole. It's not to be separated as a feature of Crohn's disease or ulcerative colitis. Then I think we have completed the intestinal features. Then moving on to the extra-intestinal features. extra-intestinal features. As far as the extra-intestinal features are concerned, the most important and the most common is going to be the arthritis, the rheumatological involvement, the joint involvement, or we can call it as musculoskeletal. As I told you, for systemic lupus erythematosus, the musculoskeletal involvement in patients with SLE is going to be the most common feature and a consistent feature of SLE. If they ask you the most common symptom of SLE, it is fatigue. Most common organ system that is associated in SLE is musculoskeletal involvement. Similarly, in patients with inflammatory bowel disease, the most common organ system that is involved is musculoskeletal. In a sense, like rheumatological involvement is extremely quite common. And especially if they ask you the joint involvement, that is supposed to be the most common extra-intestinal feature of inflammatory bowel disease. Joint involvement. Very, very important point. And when you talk about rheumatology, they'll be always asking you about arthritis. Arthritis can be, peripheral arthritis. That is what is going to be more common in patients with IBD. As we have discussed in seronegative spondyloarthritis, because they have an HLA-B27 association. That's why. So when you talk about an HLA-B27 related arthritis, you split HLA-B27 related arthritis into two, axial predominant and peripheral predominant. In axial predominant, we have only ankylosing spondylitis. In peripheral predominant, we have Retus syndrome, that is reactive arthritis, we have psoriatic arthritis, and we have this IBD associated arthritis. So peripheral arthritis is the one that is quite common in patients with IBD associated arthritis, and they can develop axial involvement as well, but that is quite rare in patients with inflammatory bowel disease. Axial involvement means we are talking about spondylitis, spine involvement, and probably sacroiliac joint involvement. So this is what is supposed to be the axial involvement. That's quite rare in patients with IBD, but peripheral arthritis is extremely common in patients with inflammatory bowel disease. But this arthritis and rheumatological involvement as a whole is quite common in patients with Crohn's disease compared to ulcerative colitis, which is not that common. But still it can happen in ulcerative colitis, but it's extremely common in patients with Crohn's disease than ulcerative colitis. Then when you talk about arthritis, typically they'll be asking about two types of arthritis in patients with inflammatory bowel disease. One is called a type 1 arthritis and second is a type 2 arthritis. I think we have discussed about this in our rheumatology topic itself, where I have told about the seronegative spondyloarthritis, where I have discussed on type 1 versus type 2. Type 1 typically is going to be oligoarticular. Type 2 is typically going to be polyarticular. You know what is the definition of oligo and poly? Oligo means less than 5 joints. Poly means more than or equal to 5 joints. Remember, usually large joint involvement is quite common in type 1 and smaller joint involvement is more common in patients with type 2. And more often type 1 will be acute and self-limiting in nature, whereas type 2 will be more of having a chronic course rather than acute self-limiting. And even more important point, that will be an institute exam point like INA, CT or JIP. Previously it's used to be very common question in JIP. It's one of the repeats that's regularly asked in JIP. So type 1 or type 2, which is more associated with the IBD course. So remember, type 1 is the one that has more correlation with underlying IBD. In the sense, like you have a flare-up of intestinal disease, you get type 1 arthritis as well. You have a type 2 arthritis usually does not correlate with intestinal disease, which means it is independent of intestinal disease. Independent of intestinal disease. Just hold on. I'm just going to put the charge. Okay, hopefully yes. We're all set to go. Okay. So we have been talking about this musculoskeletal features. In that, we have talked about two types of arthritis. One is going to be type 1 arthritis and second is the type 2 arthritis. Type 1 arthritis is going to have correlation with underlying intestinal manifestation, especially intestinal flare. You get type 1 arthritis, but type 2 arthritis usually has an independent course without any correlation with underlying inflammatory bowel disease, which means the intestinal features usually is dissociated from development or progression of this type 2 arthritis. That's why I told you type 2 is more chronic, type 1 is more acute and self-limiting, where it is typically related to flares of underlying intestinal disease, but it's more chronic in nature, type 2, and does not have any correlation with underlying intestinal disease. You get intestinal flare or not doesn't matter. So type 2 is something that's going to have a chronic course. And if they ask you which is more associated with uveitis, development of uveitis is going to be the type 2 arthritis. Type 2 arthritis is the one that has more association with uveitis as well. Clear? So these are the points that you need to know. Apart from that, you can have development of something called as HPOA, that's called hypertrophic pulmonary osteoarthropathy. So one of the important differentials of hypertrophic pulmonary osteoarthropathy is IBD, inflammatory bowel disease, even though you have multiple other causes, but it has more relationship with Crohn's disease compared to ulcerative colitis. So HPOA, you can mark Crohn's disease. Arthritis, you can mark Crohn's disease. And of course, you need to know the differences between a type 1 and a type 2 arthritis as well. Then coming on to the other manifestations, the second most important manifestation is the ophthalmologic manifestation. That's quite important. The eye manifestations. As far as the ophthalmologic manifestations are concerned, the iritis, that is the uveitis. I mean, when I talk about iritis, it means it's uveitis. So again, that has good correlation with Crohn's disease compared to ulcerative colitis. And not only iritis, the same goes for episcleritis, the same goes for scleritis and all this stuff. All these ophthalmologic manifestations in general has a good correlation with Crohn's disease compared to that of ulcerative colitis, which means it's more common in patients with Crohn's disease compared to ulcerative colitis. And third is the skin manifestations, dermatologic manifestations. There are two important dermatological manifestations that you need to know. One is going to be erythema nodosum, and second is going to be pyoderma gangrenosum. So first, let's talk about erythema nodosum. You know how the erythema nodosum lesions will be, which I'll be showing in some time. But nevertheless, erythema nodosum is supposed to be extremely common in patients with Crohn's disease, rare in patients with ulcerative colitis. Whereas when you talk about pyoderma gangrenosum, it's quite common in patients with Crohn's disease compared to patients with ulcerative colitis. Similarly, skin granulomas. So sometimes the skin granulomas are referred to as metastatic Crohn's disease, even though that name is currently avoided. But previously, the skin granulomas have been called as something called as metastatic Crohn's disease. So which means the name itself tells it's more common in patients with Crohn's disease compared to ulcerative colitis. So once again, when you take skin manifestations as a whole, it's more common in patients with Crohn's disease compared to that of ulcerative colitis. Let us describe each and every lesion now. So let me go here and put some of the images maybe, so we can talk about quite a few images. So first, it's time for images now. So let us see what are things you see here. Okay, this one, then probably this one, then we need to talk about I think we don't have the skin image. I'll just show you. Okay, so these are the two images which I want to show. So if they show images of something similar to this, so we are dealing with something called Crohn's disease. So why? Because this shows a granulomatous reaction. Granulomas. So whenever you see this kind of an image, so it's more of a granuloma. And whenever you see a granuloma without any central caseous necrosis, it's supposed to be a non-casseting granuloma. And of course, this in detail you would have studied in any pathology topics. I'm not going to discuss much right now. So this is going to be an image of a Crohn's disease in exam. So when you don't see granuloma, so here you see only a crypt. So this is a sort of a crypt that you're seeing here. And apart from that, you are seeing a kind of neutrophilic infiltrate in the center. So you have a crypt and a neutrophilic infiltrate, which means inside the crypt you have this abscess, so crypt abscess. So whenever you talk about a crypt abscess, remember it can be seen in patients with Crohn's disease with colonic involvement as well. But without granuloma, if you see crypt abscess alone, it's supposed to be ulcerative colitis. And there are multiple other differences. So these are the image, from the image standpoint, these are two images that are need to be known for exams. But apart from that, you have, like multiple other different things to note when you want to differentiate between ulcerative colitis and Crohn's disease, which I have discussed already. But these are two images which you need to know. Apart from that, I think I have an image which I'll show you about erythema nodosum and pyoderma gangrenosum. Okay, just hold on. Okay, this is the classic erythema nodosum, by the way. Yes. So what are the characteristic features of erythema nodosum? So you see in this image, the tibia is the one that is affected. I mean, the shin of the tibia is the one that is affected. You can see multiple this red color erythematous lesions, which are quite painful. In fact, if you touch them, also the patient will wince with pain, which means they are tender as well. So these are the painful tender lesions, and you very commonly see in the shin of the tibia, which is the most common site, like what you see in the image. Usually they will be approximately 1 to 5 centimeter in diameter. Remember, erythema nodosum is not specific for Crohn's disease, or it's not seen only in Crohn's disease. It can be seen in multiple other situations. But in India, one of the most common situations that causes erythema nodosum is tuberculosis. So TB is one of the important differential diagnoses. It can be seen in sarcoidosis. So why I told you TB and sarcoidosis as the first two and most important differential diagnosis? Because TB as well as sarcoidosis both are going to produce granulomas. And TB, yes, of course, classically it produces casseting granulomas, but you don't know. So TB can come in any form in India. And sarcoidosis is another condition that produces non-casseting granulomas. So there are many granulomatous conditions apart from your inflammatory bowel disease, Crohn's disease, that can result in the development of erythema nodosum. And more than that, it can happen in histoplasmosis. Histoplasmosis is something that is considered to be TB of the West. We all know that. And we have coccidioidomycosis, which can produce erythema nodosum. Then we have Yersinia infections, which can produce erythema nodosum. Then we have this blastomycosis, which can also produce erythema nodosum. Then we have, most importantly, Behçet's. Behçet's one of the most common skin manifestation erythema nodosum, which we have discussed already. So I would have discussed on something called SAVEP lesions, SAVEP for Behçet's, where we discussed about pseudofolliculitis, acneiform lesions, vesiculobullous lesions, erythema nodosum, and pyoderma gangrenosum. So the 5 lesions with Behçet's. In that, the most common skin lesion with Behçet's syndrome is also erythema nodosum. But as far as exam is concerned, so if you want to talk about erythema nodosum, most important differentials include tuberculosis in India, sarcoidosis, IBD, especially Crohn's disease, then probably histoplasmosis and Behçet's. Don't forget Behçet's. So these are the 5 DDs that you need to know. But if they ask you the most common cause of erythema nodosum in India, it is streptococcal infection. Streptococcal infection is supposed to be the most common reason for development of erythema nodosum. So these are the points. So what are the points you need to know about erythema nodosum? Let me repeat it. So it's a painful, tender, erythematous lesion, very commonly found in the shin of the tibia. It can be seen in other areas as well, but very commonly in the shin of the tibia. Approximately 1 to 5 centimeter in diameter. Important DDs include tuberculosis, sarcoidosis, inflammatory bowel disease, especially Crohn's disease, histoplasmosis, and Behçet's. It can be seen in certain drugs like sulfonamides, iodides, and all. We're not going to discuss about that, but 5 DDs which I told you already. And when you take a biopsy, what do you see? So biopsy will show characteristic inflammation of the fat inflammation, which is also referred to as something called as paniculitis. So paniculitis is the characteristic feature of erythema nodosum. Then we need to see what is pyoderma gangrenosum. Let me show pyoderma gangrenosum as well. Okay, so this is a classic pyoderma gangrenosum picture that you might get in exam. So pyoderma gangrenosum, why is, again, the most common affected area is the leg. It's not like shin or the posterior aspect of the calf, so anywhere, but very commonly in the shin. So pyoderma gangrenosum, legs, again, most commonly affected. Again, differential diagnosis in the sense like what are the conditions where you can get pyoderma gangrenosum? Apart from inflammatory bowel disease, is the fact you can get in rheumatoid arthritis, you can get in certain conditions with myelofibrosis, and you can get in certain other hematological conditions like hairy cell leukemia. And more importantly, it's a kind of a necrotic lesion. they will be having severe neutrophilic infiltration and necrosis of the local area, and then that the neutrophils is the one that is visible as a pus over here. So it means, let me write that when you have pyoderma gangrenosum, so you have a lot of neutrophilic infiltrates, neutrophils, and you're going to have a localized necrosis as well of the skin. And these neutrophils are the one that's visible as like kind of a pus. And the most important DD of underlying conditions, apart from inflammatory bowel disease, the most important is going to be rheumatoid arthritis. Very, very important point. Most important differential diagnosis is rheumatoid arthritis. It can be seen in hematological conditions also, plus or minus hematological conditions like what we have discussed, myelofibrosis and hairy cell leukemia. But more important is the IBD, especially Crohn's disease and rheumatoid arthritis. These are the two classic conditions that produces pyoderma gangrenosum when it comes to exams. And apart from that, one of the important features of pyoderma gangrenosum is its ability to produce pathogen positivity. Pathogen positivity. You know what is pathogen positivity? You know, like when you put a localized trauma, so that area will start developing papules. So especially in patients with pyoderma gangrenosum, surrounding the pyoderma gangrenosum area, if you put some small pinprick, they'll start developing these papules. It's a very characteristic condition. Like there are only two conditions where you see a positive pathology test. One is Besche, which we have discussed already, and next is pyoderma gangrenosum. Only two conditions which produces positive pathology is Besche and pyoderma gangrenosum. Clear? So there is no other area where it produces positive pathology. Clear? And pyoderma gangrenosum is also with Besche. In fact, to complicate the issue, it's also with something called Besche. So we have studied that. In Besche, you have this save P skin lesion, which I've told you some time back, and that P stands for pyoderma gangrenosum. So skin problems with patients with Crohn's disease. Do pyoderma gangrenosum resolve after colectomy in patients with ulcerative colitis? Pyoderma gangrenosum, first of all, is very rare in patients with ulcerative colitis. And after colectomy, no, it does not resolve because it's a generalized feature. So its severity may come down, but whether it will resolve or not, no. Answer is no. You need a separate treatment for patients with pyoderma gangrenosum. You need debridement and all this stuff. So it's completely different set of a treatment. And let us start with, let us go to the other features, psoriatic lesions. We talk about psoriatic lesions. Psoriatic lesions are quite common again in patients with Crohn's disease compared to that of ulcerative colitis. So then hepatobiliary manifestations. So I think this is number 5, I guess. So 4th is the extraintestinal ophthalmologic skin. Under the skin only we are going to discuss psoriatic lesions also. So now the 4th component, 4th extraintestinal feature will be your hepatobiliary lesions. Hepatobiliary lesions. So gallstones. So first start with the gallstones. When it comes to gallstones, Crohn's disease patients quite rare. There are many reasons why you get gallstones. One is the ileal area that is quite commonly affected, which causes bile acid malabsorption. So that will lead to the development of something called as cholesterol stone. So which means after ileal resection, the most common type of gallstones you get is cholesterol stones. That is due to supersaturation of bile. But before ileal resection, if they ask you what is the most common type of gallstones you get in patients with Crohn's disease, it's going to be bilirubin stones. Bilirubin stones. So gallstones after ileal resection, cholesterol. Before ileal resection, it is bilirubin stones. How we can remember? Before is bilirubin. So that's how I remember. So you can remember like that as well. Before is bilirubin stones, and after is cholesterol stones. When it comes to ulcerative colitis, basically these gallstones are very rare. And the second is primary sclerosing cholangitis, which is quite rare in patients with Crohn's disease, but quite common in patients with ulcerative colitis. I think we have discussed that fact already in hepatology section. We have discussed on autoimmune liver diseases, where we had primary biliary cirrhosis, autoimmune hepatitis, and primary sclerosing cholangitis. In that also I mentioned almost 85% of primary sclerosing cholangitis is due to underlying ulcerative colitis. Very common association. And at the same time, remember, primary sclerosing cholangitis has a strong risk of development of cholangiocarcinoma as well. So they can ask indirectly like that. Cholangiocarcinoma has a high risk of development in Crohn's disease or ulcerative colitis, not in Crohn's disease. Next, coming to the renal manifestations. Kidney manifestations. This is, I think, number 5. As far as renal manifestations are concerned, the most important is the stone disease, that is nephrolithiasis. The most important stone type is oxalate stones, and quite common in patients with Crohn's disease because of ileal malabsorption that will result in hyperoxaluria and more oxalate absorption. So again, if they ask you what kind of stones, it's going to be oxalate stones that are quite common in patients with Crohn's. That is due to fat malabsorption. The reason why we develop, we have discussed that already, and I mentioned that as well. So now going on to the complications. So we have finished the extraintestinal manifestations. That is number 5. And we're going on to the 6th one. These are the complications. What are the differences in complications between ulcerative colitis and Crohn's disease? As far as complications is concerned, the number 1 is going to be the strictures in the fibrosis. Strictures, stenosis, fibrosis. As I told you, these are the words that are regularly associated with Crohn's disease, not with ulcerative colitis. So you can put in minus. It's very rare. You don't really get in patients with ulcerative colitis. And second is fistulas. And once again, quite common in patients with severe Crohn's, rare and don't at all happen in patients with ulcerative colitis. And abscess formation, one of the very important complications in patients with Crohn's is you don't get in patients with ulcerative colitis. And malabsorption, quite common in patients with Crohn's disease, very, very rare in patients with ulcerative colitis. In fact, you don't get. This point is something we have discussed it already, I think so. I think I've told you, when you have isolated colonic involvement, you don't develop malabsorption. We have discussed it in the malabsorption separation. That's the reason why specifically ulcerative colitis is something that is not associated with malabsorption. Then toxic megacolon. Of course, there are quite few cases, like a handful of cases, like 10, 15 cases in literature is there, which can happen in Crohn's disease, but because of colonic involvement, but it's absolutely rare. And if at all it happens, it's going to happen only in patients with ulcerative colitis, at least as far as the exams is concerned. Then we talked about cholangiocarcinoma. I told you it's an exclusive complication of ulcerative colitis, not in patients with Crohn's disease. That is due to underlying PSC, due to underlying primary sclerosing cholangitis. Apart from that, colon cancer. We have discussed that in detail already. As far as the colon cancer is concerned, colon cancer is quite more common in patients with ulcerative colitis compared to that of Crohn's disease, because here dysplasia is extremely rare, you don't see. Whereas in patients with Crohn's disease, ulcerative colitis, especially those who have pancolitis, dysplasia is extremely common. They ask you what are the factors that increase the risk of development of colon cancer in patients with ulcerative colitis. The number 1 risk factor is presence of pancolitis, and number 2, if the patient is having disease for more than 8 years. Especially if you have a pancolitis and ulcerative colitis for more than 8 years, there is a high risk of development of colon cancer. Or if the patient is having left-sided colitis, isolated left-sided colitis, with a disease duration of more than 15 years. 15 years. High risk of development of colon cancer. So pancolitis with the disease duration of more than 8 years, or left-sided colitis with an equivalent disease duration of more than 15 to 20 years, which is double than that of previous. So if this is the case, then you can have a high risk of colon cancer. So there is factors for developing colon cancer in patients with ulcerative colitis. Then there are some difference in investigations as well. So what are the investigations that you're going to use? That's the 7th point. That's the 7th column that you're going to see. The difference in investigations. What investigations can diagnose what problem? So first one is the antibodies, the serological part. The antibodies. Remember, antibodies are more common in patients with Crohn's disease overall compared to that of ulcerative colitis. But you need to know this ASCA and ANCA. P-ANCA. Remember, this P-ANCA means it's not myeloperoxidase. We have discussed it already in the rheumatology section. Anti-myeloperoxidase antibodies are with vasculitis, not with ulcerative colitis or Crohn's disease. The P-ANCA we are talking about is the atypical ANCA. We have discussed it already. Go and see there if you have any doubt. So remember, Crohn's disease tends to be ASCA positive and ANCA negative usually. Ulcerative colitis tends to be ASCA negative and very commonly ANCA positive, which means almost 40 to 70% of the individuals with Crohn's disease will have ASCA positive, and less than 20% will have ANCA positivity, which means it's usually negative. And less than 5% of ulcerative colitis patients will have ASCA positive, and more than 65% of the patients with ulcerative colitis will have P-ANCA positivity. Is the voice echoing? Because there are some students who's telling that voice is echoing. Is the voice echoing or voice is fine? Okay, voice is fine. Then I think the candidate must refresh his tab. So if the voice is not echoing, then we can continue with that. Thank you very much. Okay, so what you need to know for exams is Crohn's disease ASCA positive, ANCA negative, and ulcerative colitis is ASCA negative and ANCA positive. So that's what you need to know. Okay. So then we have this other antibodies, like I told you that OMP, anti-OMPC. So that is against E. coli. We have discussed outer membrane protein component, and we have anti-I2 antibody that is against Pseudomonas, cell wall deficient Pseudomonas. We have discussed already, and we have this anti-Sabal, CBIRL. So that is against flagellin component of Clostridium species. We have discussed it already in the beginning itself. So these are quite common in patients with Crohn's disease compared to that of ulcerative colitis. Overall, the incidence is around 30-35% only. It's not seen in all the patients with Crohn's disease, but whenever these antibodies are present, as I told you, that indicates usually associated with very severe Crohn's disease. Clear? Rarely it can be present, but whenever it is present in patients with ulcerative colitis, it's rare. Usually it is not seen, but if it's present, usually that's associated with something called development of pouchitis. That's a late complication in patients with ulcerative colitis. Then coming to the inflammatory markers. So inflammatory markers are elevated in both ulcerative colitis as well as Crohn's disease. It's not like inflammatory markers are elevated only in one set. So when it comes to inflammatory markers, it's elevated in both ulcerative colitis as well as Crohn's disease. In fact, both Crohn's disease as well as ulcerative colitis patients are at high risk of developing thrombosis, especially during active disease. Both these patients are at risk of development of thrombosis, like DVT, even myocardial infarction. They're at high risk of development of thrombosis at any area, especially venous thrombosis during active stage. Especially if the disease is active and highly severe, there is a high risk of development of thrombosis in these individuals. So that you can correlate with the inflammatory markers as well, which means inflammatory markers will be elevated in both. It's not like it's more elevated in Crohn's disease or it's more elevated in inflammatory colitis. Ulcerative colitis. It's elevated in both. But one investigation that is very important is something called as fecal calprotectin. We have a separate discussion on that in IBS, that is in irritable bowel syndrome. Basically, this fecal calprotectin is a very important investigation. So especially in the setting of differentiation between IBD versus IBS, which is very common in the MGOPDs. So many times you might have IBD or IBS, both can present with similar clinical features, especially when you talk about the industrial features, both can have similar kind of manifestations. So if you want to differentiate between IBD and IBS, this fecal calprotectin is a very good screening test. So suppose if fecal calprotectin is positive, then there is a need for colonoscopy, which means it's better to proceed with colonoscopy. So if the fecal calprotectin is negative, then probably you can defer colonoscopy. So typically, fecal calprotectin is something that is like a kind of a screening test. So which means this investigation is having a very high negative predictive value, which means if the test is negative, then it literally rules out the possibility of inflammatory bowel disease. So which means if it's negative, it rules out the possibility of IBD. So that's the reason you don't do colonoscopy. You defer colonoscopy. So if the test is positive, it doesn't mean anything. In the sense like it's very low specificity investigation, which means it doesn't tell you a particular diagnosis. At the same time, it has low positive predictive value. So that is the reason why if it's positive, you cannot confirm it's an IBD. So there can be multiple other conditions which can produce positive fecal calprotectin. So you need to do a colonoscopy to confirm what is the underlying disease. So that's really, really important. So in exam, the usual question you will be getting is there an investigation to differentiate between IBD versus IBS? Answer is fecal calprotectin. If positive, it doesn't have any big value, but if it's negative, it can rule out IBD, and it can almost tell you that the patient is probably suffering from a functional bowel disorder like irritable bowel syndrome. Clear? And at the same time, more importantly, this fecal calprotectin is the one that correlate the levels of fecal calprotectin correlate with inflammatory bowel disease, which means it can be used as a marker for treatment. So if it becomes negative over a period of time, it really indicates a mucosal healing and the patient is getting better. So which means it can be used as a marker for monitoring response to therapies as well. Clear? So it's more useful compared to CRP, ESR and all this stuff, even though those are important, but fecal calprotectin, if you are practicing in a place where the patients are highly affordable, then you can use this fecal calprotectin as a marker for monitoring response to therapies as well. And one more similar kind of marker that's been suggested and proposed is fecal lactoferrin. Both are markers of mucosal injury, and especially significant mucosal injury, but nevertheless, this is another alternative that's proposed against fecal calprotectin, which is supposed to be even more specific for patients with inflammatory bowel disease, but very costly, and it's not available in all the centers. But in exam, usually your questions will be around fecal calprotectin only. That's widely studied. Alternative, if they ask you, then you can talk about fecal lactoferrin, which is relatively more specific for IBD compared to fecal calprotectin. But remember, fecal calprotectin is not at all specific. Can be seen in many other conditions, like simple gastroenteritis. It could be viral or bacterial gastroenteritis. It can be seen in celiac disease patients. It can be seen in patients who are having not only celiac disease, just a simple wheat allergy or any kind of food allergy. Patients with polyposis syndromes can have a elevated fecal calprotectin. Patients with intestinal cancer, like lymphomas, can have a elevated fecal calprotectin, which means it's not at all specific for any particular disorder. So if it's negative, it rules out IBD, more of IBS-like scenario. If it's positive, we need to do colonoscopy to confirm what is the underlying problem. Then I think we need to talk about radiology. We have talked about serology, we have talked about inflammatory markers. So it's time to discuss on radiological aspects. So some of the key points that goes in favor of Crohn's disease and ulcerative colitis. You know, in patients with Crohn's disease, the characteristic appearance that's been called is something called as a cobblestone mucosa. Again, very commonly associated with patients with Crohn's disease, especially in exams. That's the name that's been suggested. And you have something called a hose pipe or a garden hose appearance. Even though I don't know how much these are important, but nevertheless, the actual features and the pathological features are important. But still, these name designs, especially the undergraduates, are particularly concerned with this named things. So, I mean, let us go. Hose pipe, garden hose appearance, especially in the terminal ileum, is very classic word that is associated with Crohn's disease. And the string sign of contour, that is due to stricture, and like very small lumen will be left. That's what we call as string sign of contour. So these are the points that's associated with Crohn's disease diagnosis. Then loss of hostrations. Remember, hostra is a very, very important landmark in anatomy as well as radiology to tell that the area that you're dealing is the colon. So whenever you lose the hostra, which is the characteristic feature of a colon, you call it as a featureless colon, which means the colon becomes featureless. Colon becomes something similar to that of an intestine, small intestine. So that's why we call it as a featureless colon. So loss of hostra, featureless colon is a very characteristic feature of ulcerative colitis. That is due to inflammation, edema of the colon that will make the hostra to be lost. And this is what we refer to as something called as a lead pipe colon, or otherwise referred to as something called as a pipe stem colon. These are the words that are associated with the ulcerative colitis diagnosis. And apart from that, you can see the classic collar button ulcers, and you can see the inflammatory pseudopolyps. And in very severe cases, you can see the thumb printing. Thumb printing is more often associated with ischemic insults, ischemic injuries to the colon, but nevertheless, it can, again, it's a non-specific one. It can be seen in many other conditions. In any condition that is severe colitis, you can see the thumb printing. So thumb printing sign also can be seen. So let us see some images. So as we want to see, I want to show you these two images. By the way, we can see these three also. So which are usually asked in exams. The number one is the stricture. So you can see this is probably a string sign of contour, especially this is the ileocecal area. So this is the terminal ileum part. This is the terminal ileal area. This area is the terminal ileum. And you have the cecum. So cecum is here. So this is the ascending colon. So this is the kind of ascending colon here. So what you're seeing here is, like you're seeing a very small terminal ileum. So that's what you're seeing here. So that's a kind of a stricture. So you can equate this to a string sign of contour as well. So the strictures are quite common in patients with Crohn's disease. And if you see in barium enema, you can see the classic collar button ulcers. So these small things that you see here. So these are the collar button ulcers we are talking about. So these are small things that you can visualize in patients with ulcerative colitis. And once again, this is an image that shows the normal haustra of the colon. You can see here. But in this, you can see a significant dilatation of the colon. You don't see any haustra at all. So whenever you lose the haustra, this is what we refer to as a featureless colon, or otherwise referred to as a lead pipe appearance of the colon. So nevertheless, so these are the classic signature points that you need to know when it comes to ulcerative colitis and Crohn's disease. Then you do have the CT and MRI. So as I told you, these are the barium findings that we saw. Then when it comes to the CT and MRI findings, in CT and MRI, once again, you see a characteristic sign called as a creeping fat sign. That's due to surrounding inflammation. Usually, it's very rare. You don't see creeping fat sign in patients with ulcerative colitis. Why you see this creeping fat sign? Because inflammation in Crohn's disease is transmural. It will affect the surrounding mesenteric fat also, which results in this kind of creeping fat sign. Alternative to that is what we refer to as a MCOMS sign. That's how it looks. And again, seeing this sign is beyond the scope of the current discussion. When it comes to ulcerative colitis, you see a characteristic sign called as a fat halo sign, which is a completely different sign. So just remember the names if at all you want. That's more than enough for exams. So remember, then move on to the colonoscopy findings. So what are going to be the colonoscopy findings? Patients with Crohn's disease and ulcerative colitis. Remember, colonoscopy with biopsy is considered to be the current gold standard. But remember, ideally, to be honest, you have to do ileocolonoscopy, because in Crohn's disease patients, sometimes if you do only colonoscopy, you might miss. So even though, like ileocolonic disease is the most common in patients with Crohn's disease, but there are quite a few number of patients, in fact, substantial number of patients where you can get only small intestinal disease, that is terminal disease only will be there. So it's a kind of, it's better to do an ileocolonoscopy. It's always, like any gastroenterologist, if you if they want to do a colonoscopy, they don't do just a colonoscopy. They try to advance it to the terminal ileum also, and they tend to see the terminal ileum. This is a very common thing done by most gastroenterologists, unless until you do only a sigmoidoscopy. If they go for colonoscopy, they tend to go into the terminal ileum and have a look at the terminal ileum as well. So that's what we call ileocolonoscopy. So which is anyway, colonoscopy is supposed to be the gold standard investigation for diagnosis of any patient with inflammatory bowel disease. So what will be the classic findings that you will see? Typically, you will be seeing this kind of serpentinous ulcer. So let me insert an image and show you what's really seen here. Maybe I can insert these two images first. So what you're seeing here is this kind of linear serpentinous ulcers. So this is a classic word. So that you see in patients with Crohn's disease. So you see this kind of linear serpentinous ulcers that will be going all the way down throughout the intestinal wall, which is typically transmural in nature. So this is very characteristic in the terminal ileum. And if you see this kind of picture, and probably if you talk about the serpentinous ulcers in colonoscopy, so they are talking about this Crohn's disease. If you see serpentinous ulcers in esophagus, what are they? Basically, they are nothing but CMV esophagitis. But if you see serpentinous ulcers in the terminal ileum, you're talking about a Crohn's disease. And typically, this is the cobblestone appearance of the mucosa in patients with Crohn's disease. And this is due to ulcerations and probably a little bit of pseudopolyps, creating a cobblestone mucosa-like appearance. Cobblestone-like appearance. And let us see what you will see in patients with ulcerative colitis. So let me insert these two images probably. So what are really seeing? Here is seeing a significantly edematous colon. which means these are the areas of edema which has been mentioned here. And at the same time, you can see these ulcerations with pus. I mean, these white color exudates are there. And remember, the exudates can be very severe, where sometimes there are severe ulcerative colitis patients who can exhibit the formation of pseudomembrane also. So, but nevertheless, pseudomembrane in exam is usually in colon. If you see, it is associated with Clostridium difficile colitis, that is pseudomembranous colitis. But in very severe cases of ulcerative colitis, we have seen pseudomembrane-like formation that is due to severe exudate that are coming out. So these are due to fibrin deposition, exudates and fibrin deposition. That white structures that we are seeing, along with it, this is the edematous colon that we are seeing here. Clear? And the mucosa will be very thin and friable, and it's going to bleed very easily. Sometimes when you do colonoscopy itself, the insertion of the like the scope itself sometimes can break the mucosa, and it can result in significant bleeding at some places, which are very important again. And what is this image? These are the characteristic pseudopolyps that is seen in the colon in patients with ulcerative colitis. So these are the 4 images I need to show: the serpentinous ulcers, cobblestone mucosa, edematous colon with exudates in patients with severe ulcerative colitis, and inflammatory pseudopolyps in patients with ulcerative colitis. And apart from that, when it comes to monitoring of patients with Crohn's disease and ulcerative colitis, so this is the probably 8th concept that we're going to see. What are the scores that are used for monitoring? So which means we have different activity scores. Activity scores are there. Activity scores are there. The most commonly used activity scoring, the disease monitoring activity as far as Crohn's is concerned, is called as CDA. That's called the Crohn's disease activity index. If at all they ask you what are the like components of Crohn's disease activity scoring or CDA, so you have a certain few things. So first, number of liquid stools per day. Number of liquid stools per day. So then it has a score of 2 almost maximum. And then you have abdominal pain, of course, which is a very important feature of Crohn's disease. So depending on that, you have a score of 0, 1, 2, and 3. You have 0 means none, then you have 1, I mean mild pain means then you have a score of 1, then you have a moderate pain means score of 2, and severe pain score of 3. It's again more subjective in nature. And the patient can also comment on their general well-being. So again, it has a score of here 0 to 2, I mean 0 to 4. And abdominal pain, as I told you, it can range from 0 to, the score can range from 0 to, it's any number. So which means if this patient has 10 stools, then you can score as a 10 also. So number of liquid or soft stools per day, abdominal pain, general well-being, where the patient tells how they feel about the disease, from a score of 0 to 4. And similarly, what are the number of complications? We are talking about extraintestinal as well as intestinal complications, the total number of complications that the patient is having, like arthralgias, uveitis, skin manifestations like erythema nodosum, pyoderma cancrenosum, aphthous ulcers, fissures, fistulas, abscess formation, fever, and strictures and obstruction. So all these things are considered to be complications. So what is the total number of complications that the patient is having? And are they using opiates for diarrhea? Use of opiates for diarrhea, like loperamide. So have they used opiates for diarrhea recently? And is there any abdominal mass in the patient? So clear? Apart from that, hematocrit is very important. Is there any deviation from hematocrit? So it means reduced or increased. That's what we're going to see. And weight loss. So these are the 8 parameters that you use in patients with CDA, that is Crohn's disease activity index. So in that, number of liquid stools per day, abdominal pain, generalized well-being, complications. What is the total number of complications? Have they used any opiates for diarrhea, abdominal mass, whether it's present or not, or it's questionable, then deviation from normal hematocrit, and finally weight loss. What is the amount of weight the patient has lost recently. So these are the points that you need to know as far as the Crohn's disease activities index is concerned. This is the most commonly used tool and the gold standard right now for monitoring the activity of Crohn's disease. Apart from that, you have multiple index, like something called as Van Hees index. Then you have the Talstad index. Then you have the D. Domball's index. Then you have Harvey Bradshaw index, Cape Town index, and IBD, International Organization of IBD index, which is given by Oxford University. So many different forms of index are there, but at least for exams, you need to know this CDAI. So that is Crohn's disease activity index. Then we have something called as True Love and Wits criteria for measuring the activity of ulcerative colitis. Very, very, very important, which is usually referred to as something called as Travis criteria also. Travis criteria is more important for severe ulcerative colitis, but True Love and Wits criteria will tell you whether it's mild, moderate, or severe ulcerative colitis. So if you want to know Travis criteria is exclusive to tell whether it's a severe ulcerative colitis or not. But True Love and Wits criteria can tell you whether it is mild ulcerative colitis, moderate ulcerative colitis, or whether it's a severe ulcerative colitis. All these things can be told by True Love and Wits criteria. So let us see what do you mean by True Love and Wits criteria. So based on True Love and Wits criteria, you can actually classify the disease into mild ulcerative colitis, as I told you. Then you have moderate ulcerative colitis, or maybe more than moderate, you can call severe and fulminant. Severe ulcerative colitis and fulminant ulcerative colitis. Or you can remember mild, moderate, and severe. I mean, almost all the same, but the understanding is quite simple. So first, you need to know the total number of stools per day. There are quite few points that you know, especially the components. Number one is the number of stools per day, less than 4 mild, more than 6 severe, more than 10 is supposed to be fulminant. And is there any blood in stools? Blood in stools. So usually a small amount of blood in stools is considered to be mild. Frequent blood in stools is considered to be severe. And if it's continuous, not even intermittent, continuous blood in stool coming throughout every stool, that is considered to be fulminant disease. Then when it comes to temperature, what is the fever the patient is having? Normal, the patient is having fever, it's either severe or fulminant. Then when it comes to the pulse rate and the heart rate, usually mild patients will have a normal pulse rate. Fulminant and severe patients will have tachycardia, usually means here more than 90. Then when it comes to hemoglobin, remember in a cardiological perspective, tachycardia means more than 100, but there are some areas where tachycardia is considered to be more than 90. Like for example, in SIRS, you have studied systemic inflammatory response syndrome. There again, if they want to know tachycardia, it is more than 90, and in certain areas like sepsis panel, you know, like again the tachycardia there is supposed to be more than 90. So there are some areas where tachycardia means it's more than 90. So don't think it's more than 100. Even though from cardiological perspective, tachycardia means more than 100. Then when it comes to hemoglobin, we are talking about the presence of anemia or not. So normal hemoglobin especially means more than 70% of normal hemoglobin. In the sense, like if it's more than 70% of what is supposed to be normal for their gender and age, that's considered to be normal. In the sense, let's mild disease. If it's less than 75% of normal hemoglobin, which means I'm talking about a reduced hemoglobin, that's considered to be severe here. And if they need a transfusion, if there is any anemia that warrants transfusion, that's considered to be a fulminant disease. And again, as far as ESR is concerned, erythrocyte sedimentation is concerned, less than 30, more than 30, more than 30, which means it's normal. Here it is increased. That's all. So these are the 6 features of True Love and Wits criteria. So it's quite cumbersome in the sense, like it's quite complicating. It's not that easy to remember. So that is the reason why, you know, like they have introduced something called a Travis criteria. Travis criteria is something used to tell whether the patient is having severe ulcerative colitis or not. So what is the Travis criteria tell? This is more easier, and this is what is going to be more important in the current practice. Like for example, any patients who have more than 8 stools per day, any patient who is having more than 8 stools per day, plus CRP more than 45, or the patient is having 3 to 8 stools per day plus CRP more than 45. So this indicates that the patient is likely having a severe ulcerative colitis. And this also means that whatever therapy you are giving right now is inadequate and you have to push to a alternative therapy. In the sense like you have to go for the next chance of therapy. 85%. So this indicates 85% chance of patients developing severe colitis. 85% chance of patient developing very severe colitis. And it also tells you that whatever therapy that you are doing right now should be escalated. You have to move to the next line of therapy. So that's what it indicates. So that's what you need to know. So that's what about Travis criteria. So we have true love and Witts criteria, and we do have the Travis criteria as well. Then apart from that, we have the Mayo score. We have UCDA. UDCA is a drug that is used for primary biliary cirrhosis. Sorry for that. So there's something called UCDA. That's called Ulcerative Colitis Disease Activity Index. But nevertheless, the two most commonly used in any medical gastroenterology practice right now is true love and Witts criteria, and more important with the current practice, the Travis criteria, which tells you 85% chance of having severe colitis. That is stools more than 8 or 3 to 8 per day plus a CRP more than 45. So these are the important points that you need to know. So when it comes to monitoring disease activity, for Crohn's disease, it's CDI, Crohn's disease activity index, and for ulcerative colitis, it's true love and Witts criteria and Travis criteria. The more important one is the Travis criteria. So now treatment. So monitoring is done. So now the 9th point is the treatment. 9th segment that you're going to discuss is on the treatment aspect. So the first thing that you need to know is Crohn's disease is incurable. It can go for remission, you can control the disease, but it's basically incurable. Whereas ulcerative colitis is a disease that is curable, but only by surgery. You need to remove the colon, affected area. Then only you can treat the ulcerative colitis. Otherwise, you cannot treat the ulcerative colitis. And there are some medical management are there. There are surgical management are also there. So medical management is basically based on the severity of Crohn's disease, that too on CDA, that is Crohn's disease activity index. So let us talk about medical management first. Then I'll talk about surgical management, indications for surgery. Medical management, so depends on whether you're having a mild Crohn's disease or you're having a moderate to severe Crohn's disease. So what do you mean by mild Crohn's disease? If you have a CDAI of in the range of 150 to 220, this is called mild Crohn's disease. Remember, CDAI of less than 150 means the disease is in remission. So you do not really treat them. So if it's in the range of 150 to 220, then we call it as mild Crohn's disease. Anything more than 220, CDAI more than 220, it will be moderate to severe. For example, 220 to 450 is considered to be moderate, and CDAI more than 450 is considered to be severe or probably fulminant colitis. Fulminant Crohn's disease. So when the patient is having mild Crohn's disease, the first line treatment is usually steroid or probably the mesalamine, ASA derivatives. That's what we use. So typically the options could be either a 5-ASA derivative, or alternatively you can use steroids like budesonide. So where will you use 5-ASA? 5-ASA typically used in colonic predominant Crohn's disease. The patient is having more of a colon predominant Crohn's disease, then you can use 5-ASA derivatives, especially as rectal suppository, or probably even oral is not that great, but rectal suppository is what we use. So 5-ASA derivatives like mesalamine, mesacol, so many brands are there, which we'll be discussing after some time. And steroids typically used for ileocolonic disease, which means whenever the small intestine is involved, you go for steroids. Ileocolonic CD or a small intestinal, typical small intestinal Crohn's disease, you're going to use steroids. So colon is involved predominantly, or only colon is involved, think about 5-ASA derivatives. If ileocecal or small intestine is involved, involvement is predominant, then in that condition you can go for steroids. So most of the time it will be ileocolonic disease. So that is the reason why most of the patients with Crohn's disease will be on steroids. Moderate to severe Crohn's disease, irrespective of the disease type, we are going to use steroids as a mainstay of treatment. Very important. So once the steroids are not responding, or probably your first line therapy is not responding, if there is no good response, which means, your complete remission is not achieved. In that setting, you have to escalate the therapy to either anti-TNF alpha, it's one of the very good therapies for Crohn's disease, like adalimumab, or probably you can go for infliximab. So anti-TNF therapy. We have seen different anti-TNF therapies. What are the different drugs that contribute? But very commonly in India, we use either infliximab or probably adalimumab. Or alternatively, you can use azathioprine or probably 6-mercaptopurine, which is actually like azathioprine only. And you can use methotrexate also. But you're going to use any one of them. So you're not going to use combination, either azathioprine or 6-mercaptopurine or methotrexate. But in my practice, I generally go for anti-TNF alpha, which I feel is more effective than these drugs. But no studies will tell that there is any difference between these drugs. It's all about your personal practice. And if you still don't see any much response, the patient doesn't go for complete remission, then you can use a combination of anti-TNF alpha drugs plus any one of either azathioprine or 6-mercaptopurine or methotrexate. Any one. Again, you don't use a combination, you're going to use any one. So in this, there's no other option. You're going to now use a combination of the anti-TNF alpha, that is subcutaneous drug, which is the monoclonal antibody, plus along with it, you're going to use an oral drug like methotrexate, azathioprine, or 6-mercaptopurine. So this is a biological, this is a disease-modifying agent. This is a disease modification. You're going to use a combination of these two drugs if this patient is still not responding. If you still don't get the response, then you can use some modern therapies, novel therapies like natalizumab, if it is available. Natalizumab, it is also used in patients with multiple sclerosis. We have discussed that already. But nevertheless, it's one of the other uses, Crohn's disease. Apart from that, we can use something called vedolizumab as well. So what do you mean by natalizumab and what do you mean by vedolizumab? So what is the mechanism of action of natalizumab and vedolizumab? Anyone? Natalizumab we discussed already in multiple sclerosis, so you need to tell. Yes, alpha-4 beta-1 integrin inhibitor. So that's a monoclonal antibody that is direct against alpha-4 beta-1 integrin. So what alpha-4 beta-1 integrin does, it binds with something called as VCAM1. That is vascular cell adhesion molecule 1. So that's where it binds with. So whereas vedolizumab is again an integrin inhibitor only, but it inhibits alpha-4 beta-7 integrin, which means it's a monoclonal antibody against alpha-4 beta-7 integrin, which is actually going to bind with something called as MADCAM1. So this is something called as mucosal vascular addresin cell adhesion molecule 1. So AD stands for addresin, ADD RESSIN. So mucosal vascular addresin cell adhesion molecule 1. That's what it's going to bind with. So the problem with this VCAM1. So for example, if you take about this VCAM1, vascular cell adhesion molecule 1, it is present in both brain, that is blood-brain barrier, as well as GAT mucosa, gastrointestinal mucosa, present in both. So that is the reason why when you give a natalizumab, that has a risk of development of PML, that is progressive multifocal leukoencephalopathy, because of JC virus. That's because it has effect on the brain as well. But this MADCAM is something that is present only in the GAT mucosa, in the sense like it's not seen in the brain. So theoretically speaking, vedolizumab has much more advantage in reducing the risk of PML, progressive multifocal leukoencephalopathy, compared to the natalizumab. So for multiple sclerosis, we need this brain action. So there's no other, no option there. So you have to use natalizumab only. Vedolizumab cannot be used in multiple sclerosis because it doesn't have any action in the brain. It acts on MADCAM, which is not even present in the brain, blood-brain barrier. So vedolizumab will not be effective in multiple sclerosis at all in the first place. But natalizumab, one problem is it is effective, but because of its brain action, that is useful in multiple sclerosis, becomes a villain here, because if we don't want that brain action in patients with Crohn's disease, so we don't want that PML. That's why in patients with Crohn's disease, theoretically speaking, vedolizumab will be much better because it has a theoretically low risk of producing progressive multifocal leukoencephalopathy. Apart from that, there are quite a few complications that you can expect in patients with Crohn's disease. For example, you can develop fistulas in patients with Crohn's disease. These are like very important complications of patients with Crohn's disease. Usually, fistulas in Crohn's disease tends to be very complex, and most of the time, they don't obey the good salts rule. complex and they doesn't obey the good salts rule. So what is good salts rule, anyone? Because there are quite a few number of students are here. So you can type 10 seconds time. What is good salts rule? So 10 seconds is up. So good salts rule says that, don't mistake me. Usually I used to remember when anyone called ass because like you are dealing with an ass. In the sense like you are talking about fistulas in ano. So you can remember by this not a very good mnemonic for certain students, but nevertheless, I remember by something called AS. A stands for anterior fistulas. They generally have straight tracks. Anterior means straight, so that's what I remember. And posterior are curved, generally. But even though you have exceptions to good salts rule, one of the important exceptions to good salts rule is Crohn's disease. And when you talk about surgical theory, when you go to the Bailey and Love surgical textbook, that are given anterior tracks that are more than 3 centimeters away from the anal verge is an exception because they tend to be curved. The tract will be curved. So in general, the good salts rule says that anterior tracts are supposed to be straight. That's how, remember, as straight. And posterior tracts are supposed to be curved. And one exception for the rule that's given in surgical textbooks is more than 3 centimeter. The tracts that are fistulas that are more than 3 centimeters away from the anal verge, even if they're in anterior area, they're supposed to be curved in nature. So that's what the good salts rule say. But I believe more than that, when it comes to medicine, the most important point is Crohn's disease fistulas generally disobey the good salts rule. They don't really obey the good salts rules. That's the most important point that you need to know. So we have multiple different, more than the good salts rule, we have some classification of fistulas in surgery. So typical classification that we use is something called as Parkes classification, where you divide the fistulas into intersphincteric, suprasphincteric, transsphincteric, extrasphincteric. A lot of differentiation is there. But as far as the diagnosis of these fistulas is concerned, if at all they ask you the gold standard, it's always going to be examination under anesthesia. This is going to be the gold standard. When it comes to non-invasive investigations, remember examination under anesthesia means you're going to really make the patient lie down and you're going to put your finger into the fistula and examine. So that's going to be the gold standard. Examination under anesthesia, put a proctoscope, finger and examine. So that's gold standard, but it's more invasive. Patient will be painful. You need anesthesia for that. So that's why to avoid all this, you have a set of non-invasive investigations where you have 2 non-invasive investigations. One is endo-anal ultrasound, which is not that good. Especially when it is complicating fistulas, endonal ultrasound is not that useful because endonal ultrasound has a penetration depth of only 2 centimeters around the anal verge. So in the sense like if the fistula is beyond 2 centimeters or 3 centimeters, that's very common in patients with Crohn's disease. This complicated fistulas may not be able to visualize properly. That's it's not a very good investigation in patient with Crohn's disease. So, but in patients with Crohn's disease, one non-invasive investigation which is particularly helpful, that is MR fistulogram. MRI, very, very good investigation. In fact, in any fistula in ano, one of the most important investigation is MRI. So MR fistulogram is considered to be the non-invasive investigation of choice. Even the examination under anesthesia is a gold standard. MR fistulogram is considered to be the non-invasive gold standard or non-invasive investigation of choice. Any fistula in ano, especially for patients with Crohn's disease. And as far as the treatment of fistulas are concerned, there are some similar treatment that what you can use. For example, medical therapy you can try in patients with fistulas because these are due to inflammation. So you control the inflammation, your fistulas are going to close. So for example, you have some antibiotics, especially metronidazole is very commonly used in patients with fistulas, especially metronidazole. That's something you need to know. And apart from that, you can use the anti-TNF alpha drugs, which are considered to be the most effective of all. The most effective drugs of all in Crohn's disease fistulas. And apart from that, you can use the disease modifying agents, which I've told you, like methotrexate, azathioprine, 6-mercaptopurine, that also can be tried, but these are supposed to be the most effective. So remember, many times you need to have a combined surgical approach. It's not like you're going to treat completely medically, so you have to always get the surgeon's input as well. Especially if it's a complicated fistula, the surgeon generally puts something called as loose statins. Loose statins. So remember, never use cutting statins. There are something called cutting statins also. Cutting statins are something that has to be completely avoided in patients with Crohn's disease. It has always to be loose statins, because cutting statins generally itself has a high risk of developing incontinence. But especially in patients with Crohn's disease, they have a serious impact on continence later on. Most of them will be young to middle-aged people, so please avoid that. So patient will invariably go for incontinence. So in surgery, there are certain areas where you use cutting statins. There are certain areas where you use loose statins. So in cutting statins, you actually cut out the fistula tract and try to heal by heal by something called secondary healing. And loose statins, it just keeps the fistula open, and why you put loose statin? You want to keep the fistula tract open, and you want to abolish the secondary tracts. So that's why you use loose statins. Cutting statins, you cut out the fistula from the side and you heal by secondary healing. So, but cutting statins, the problem is it has a high risk of developing, like incontinence. That's why they don't use it. Loose statins are the way to go in patients with Crohn's disease. You never ever use cutting statins in patients with Crohn's disease because of serious risk of incontinence. Apart from that, you have multiple other therapies like fibrin glue is there, fistula closing devices are there, stem cell therapy has been tried. But these are the options. That's all. Crohn's disease, these are two things. But more important is the medical treatment. Surgical is an adjunct where it can help the patients, but medical treatment is the best. But remember, any patient, especially young patients who are coming with a non-healing fistula, one of the important differential diagnoses is Crohn's disease. You would see that Bailey and Love also. It's a very important point that to know. Any patient who's having a non-healing fistula, especially a young patient, young to middle-aged patient coming with a non-healing fistula or a complex fistula or a fistula that disobeys the good salts rule, you think about a Crohn's disease. Very, very, very important. And one more important classification system is available for patients with Crohn's disease. We discussed the activity index, but as a Crohn's disease as a whole, we have some classification system. This is for Crohn's disease as a whole, not just for the severity or activity monitoring. So that's called as Montreal classification system. Montreal. Remember, we have Vienna also. We have a separate classification system called Vienna classification system also. But Montreal is the one that is commonly used and it's widely preferred by majority of the gastrointestinal societies. So based on Montreal classification system, you have three components in Montreal classification system. One is the age, and next is the location of the disease, and the third one is the disease behavior of the disease. As far as the age is concerned, so we have split into A1, A2, and A3. A1 stands for age. Crohn's disease in patients who are in teens and adolescents less than 16 years. A2 for young adults like 17 to 40 years, and little bit older adults more than 40 years is A3. And we have location. In that you have L1, L2, and L3. Location number 1, which means the patient is having only terminal ileal disease, nowhere else. And L2 is isolated colonic disease. It's quite rare. L3 is ileocolonic disease, which is the commonest. And as far as the disease behavior is concerned, we have B stands for disease behavior. B1 is non-stricturing and non-penetrating disease. Non-penetrating. B2 stands for stricturing disease, and B3 stands for penetrating disease. So these are more severe forms. So this is how you classify Crohn's disease. This is what we refer to as a Montreal classification system for Crohn's disease. I think that sums up the different management options as far as Crohn's disease is concerned. And there are quite a few indications of surgery. So that's something which you need to know. Indications for surgery. As for the indication for surgery is concerned, number 1, symptomatic bowel disease, small bowel disease. Symptomatic small intestinal disease is an indication for surgery. So remember, this is the most common indication as for patients with Crohn's disease. Remember, And again, surgery should be done only in patients with symptomatic Crohn's disease. If the patient is asymptomatic, you should not do any surgery. So usual indication will be usual symptom that becomes an indication for surgery is either a stricture or a stricture causing an obstruction. So stricture, obstruction are usual common indications. And the most common surgery that is done in patients with Crohn's disease is terminal ileal resection. That's the most common surgery that is done. Second most common indication for surgical consult is the perianal disease. Perianal disease, especially fistula and abscess. So I told you fistula is generally treated under surgical consult by loose sedans, and abscess generally drained out, as you see. So this is the second most common indication. So why you want a surgical consult? Most common reason for surgical consult is symptomatic spondylosis disease like obstruction stricture. The second most common indication is perianal disease like fistula and abscess. Maybe the last but not the least one important indication, intra-abdominal abscess, which is not that common in patients with Crohn's disease. Actually seen in very fulminant and severe Crohn's disease patients, but overall its incidence is not that disturbing. So intra-abdominal abscess is also an indication for surgical consult in patients with Crohn's disease. Remember, as I told you, surgeries in Crohn's disease will not be curative. Indication for surgeries in Crohn's disease is not curative, which means it's done only to reduce the symptom severity. So surgeries in Crohn's disease should not be done with a curative intent. But surgeries in ulcerative colitis we do with a curative intent. But surgeries in Crohn's disease is never done with a curative intent. It's done to supplement your medical management and to reduce the severity of the symptoms. That is the reason why, as I told you, the most common surgery that is done in patients with Crohn's disease is terminal ileal resection. So, or we call it a segmental resection. So that's what is done in Crohn's disease usually. Extensive resections are basically avoided in patients with Crohn's disease because once you do a resection, later on the patient may go for stricture again. So you might be needing to remove that part again. So which means segmental resections are the surgeries that are usually done in patients with Crohn's disease, and with special regards to terminal ileal resection, which is the most common surgery that is performed in patients with Crohn's disease. Clear? So remember, Crohn's disease surgeries are not done with curative intent. So it has to be done only in symptomatic patients, and at the same time, like extensive resections in patients with Crohn's disease should be generally avoided. So you don't do that. And when it comes to ulcerative colitis, as far as ulcerative colitis is concerned, you treat medically as well as surgically. But remember, medical is first tried, but even though surgery is curative in patients with ulcerative colitis, so you divide into whether you have a mild to moderate disease or you have a severe disease. Basically, anything that satisfies Travis criteria will come under severe disease. If you don't satisfy the Travis criteria, it will come under mild to moderate disease only. So any patient with mild to moderate disease, you're going to use 5-ASA derivatives as a first-line therapy, which means, like I told you, even in patients with Crohn's disease, if it's limited to the colon, you're going to treat with 5-ASA derivatives only. So which means here the disease is affecting only the colon, so definitely 5-ASA derivatives will be very effective. And if it's not showing any sufficient response, the patient is not going for any remission, then it's better to use a combination therapy of 5-ASA derivatives along with oral or topical steroids. But we generally go for oral steroids, topical steroids in the sense we are going for rectal suppository of budesonide, but in general we go for oral steroids. But remember, when the disease is affecting colon, it's always better to give suppositories. When the disease is not affecting colon, then it's better to go for oral therapy. So for example, if the patient is having more and more small intestinal disease, the oral therapy will be effective. If the disease is affecting more and more distally, like colon and rectum, the more it goes towards the rectum, the suppositories will be more effective. That's how the gastroenterologists play a role. Like in the sense, like, anyway, so once the initial 5-ASA therapy is not that effective, then you're going to move ahead with combination therapy of 5-ASA with steroids. So that's the idea. So then still, if you don't get sufficient response, then you need to start with IV steroids along with a combination of azathioprine or 6-mecaptopurine. In patients with severe disease, you have to immediately admit the patient. They have to start with IV steroids immediately, as soon as possible. Suppose if the patient is still not responding to this therapy, then it's better to start with calcineurin inhibitors like cyclosporin or tacrolimus, or alternative to calcineurin inhibitors will be anti-TNF alpha drugs like infliximab or adalimumab. Anti-TNF alpha drugs can be started. typically, because the patient is admitted, we give infliximab. Remember, adalimumab is subcutaneous, infliximab is IV, intravenous. It's not given subcutaneous. So because the patient is admitted, we try to give an IV drug that is infliximab, but you can prefer adalimumab also. There is no much difference in efficacy. Suppose the patient is not responding in mild to moderate category with IV steroids, of course, you're going to go for calcium inhibitors. So what is the take-home point here? If the patient is not responding to IV steroids, then the next step is to go for calcium inhibitors or alternatively anti-TNF alpha drugs. Still, the patient is not having a sufficient response, then it's better to go for surgery. So this is the usual flow of therapy in patients with ulcerative colitis. So let us compare with Crohn's disease patients. So Crohn's disease, mild patients, we start with, either a 5-ACE derivative or a steroid, depending on where the involvement is. If it's more of a distal colonic area, then you go for 5-ACE derivative. It's more of proximal ileocolonic or small intestinal disease, you go for steroids. So if it's moderate to severe, then you're going to go for steroids directly. If steroids are not responding, then you're starting with anti-TNF alpha as the next drug, or probably alternative, you can start with one of the disease-modifying drugs. If still they don't have sufficient response, then you can go for a combination of biologicals and disease-modifying drugs. If still the patient doesn't show any response, you can try one of these two drugs like natalizumab or vedolizumab, which are investigational right now, and it's approved, but still we don't have sufficient experience with those drugs because they are very costly and they are little complicated drugs. And apart from that, you have therapies for fistulas, you have therapies for abscess, you have some indications for surgery, which I've told you, but most important in Crohn's disease is the medical therapy. That's going to be more important. Whereas in patients with ulcerative colitis, medical is important, but still surgery is also important because it provides a curative options in patients with ulcerative colitis. When it comes to medical therapy in patients with ulcerative colitis, once again, because the disease is more distal in nature in ulcerative colitis, we try with ACE derivatives first. If it doesn't respond, then you add steroids. If it doesn't respond, then you give IV steroids. If it doesn't respond, then you go for calcium inhibitors or anti-TNF alpha drugs. Similarly, for severe disease, straight away start with IV steroids because there's no role for any oral drug here or rectal supposed here because the disease is severe. If the IV steroids doesn't respond, as I told you, the next step will be either adding a calcium inhibitor or a anti-TNF alpha drug. If still the patient doesn't have sufficient response with calcium inhibitor or anti-TNF alpha drug, it's better to go for surgical option. So this is how you're going to treat a patient with ulcerative colitis. But please understand, you have two types of surgeries. One is acute severe colitis, where you do emergency surgery. Like for example, a toxic megacolon or something else. Toxic megacolon is an absolute indication for doing a emergency surgery. We know that. Or you can have intractable colitis, or patient is having a dysplasia, or patient is having a carcinoma colon. Because of that, you want to do a surgery. So where you do a elective surgery, you don't do an emergency surgery, where you're going to do an elective surgery. So there are many different surgeries that are preferred. For example, one of the most important elective surgeries that are preferred, this is a very common question in exam, that is called as total proctocolectomy, which means you remove the rectum, that is procto, and you remove the entire colon, colectomy. So total proctocolectomy, and you have only the ileum left. So you are going to combine with the ileum with the anus by creating a pouch like structure with the ileum, that is called as ileal pouch, anal anastomosis. So this is the preferred surgery right now. So total proctocolectomy with ileal pouch, anal anastomosis. This surgery can be done as a single procedure in a single step, or a staged procedure. You can do this in 2 stages as well. But most of the time in my hospital, like surgeons tend to do it as a single procedure. But there are some hospitals where they do it as a staged procedure as well, in a 2-stage procedure, as a 2 months interval they do. But let us come back to that. And then you go to the acute severe colitis, where you do emergency surgery. So remember, in emergency surgeries, the most important thing is rectum is not removed. Here they will do total colectomy. Total colectomy in the sense they remove the colon, but rectum is not removed. And they divert the ileum. So now when the colon is removed but the rectum is left, now you will have the ileum that will not be attached to the colon. They will actually put an ileostomy, end ileostomy, with an ileostomy bag, the ileostomy pouch. So That's what they do. So rectum will be just closed as a stump, and later on, after 3 months, they will. So after 3 months, once the patient settles down, so I mean, you would have studied something called damage control surgery. It's one of the first chapters in Bailey and Law. Would have studied that. So in emergency conditions, it's better to control the damage first. Later on, you go for the definitive therapy. So after 3 months, this rectum should be removed because rectum is a very important source of problem in patients with ulcerative colitis. So it should not be left. So it should be removed. So which means you do the proctectomy. So you're going to remove the rectum. That's called proctectomy. Plus, you can go for ileal pouch anal anastomosis, which means now the ileum that is attached with the skin, that is end ileostomy, can be diverted, and now you can attach with the anus and creating a pouch in the terminal portion of the ileum, that is called ileal pouch anal anastomosis. So you can do it as a two-stage procedure in patients with acute severe colitis. So this is how they do the surgeries in reality, depending on whether it's a emergency scenario or depending on whether the patient is having a elective scenario. So let me insert an image so that you will understand this surgeries better. So let us see these surgeries. So what's happening here? So okay, as I told you, the ileal pouch anal anastomosis can be done in a single stage procedure or a two-stage procedure. This is a classic example of a two-stage procedure where the surgery is done in 2 visits. First, what they do is they create an ileal pouch first, and they put a diverting ileostomy. This is step 1. After 3 months, maybe after 2 to 3 months, what they do is they do something called ileostomy takedown, where they remove the ileostomy and they create the ileal pouch anal anastomosis finally. So they, which means they wanted to allow this pouch to mature. That is the idea. Most important idea here is they wanted the pouch to get matured here. So for that, they wait for a period of 2 months. Till that, the ileostomy will help in taking the stools out. So that's why it's called a diverting ileostomy. Then after 2 months, once the pouch is matured, then the stools will be passed through the ileal pouch anal anastomosis, and they will take down the ileostomy, and they will do an end-to-end anastomosis, and that's called ileostomy takedown. So this is two-step procedure we are talking about when it comes to elective surgeries. When it comes to emergency surgery, what they do is they don't remove the rectum. Here, if you see, the rectum is not removed at all. Rectum is still left, so it's not at all removed. Sorry, here the rectum is still left. Here the rectum is not removed at all, and you have done a total colectomy, so which means there is no colon here. So the patient has been taken for total colectomy. Rectum is not removed. Rectum is still there, and they have put an ileostomy. Maybe after some time, what they do is they will put a ileal pouch anal anastomosis. This is sort of emergency surgery they do. So first, colectomy alone, remove the colon alone, which is the most problematic part that is causing the acute complication right now, and put an end ileostomy, leave the rectum, damage control surgery. Then after some time, once the patient gets better, you remove the rectum also, and you do a ileal pouch anal anastomosis. That's all. So these are the type of surgeries that you need to know. So 2 types of surgeries, emergency and elective, and how they do also is very, very important. And one more important thing, what they will be asking you is when to start with the screening colonoscopy in patients with ulcerative colitis. So remember, as I told you, ulcerative colitis patients has a high risk of developing dysplasia and subsequent colon cancer. So you need to know. So how frequently or when you will start doing a screening colonoscopy in patients with ulcerative colitis. So usually it started around 8 years. Typically it's around 8 years from the time of diagnosis in any patient. And thereon, once you do a colonoscopy at 8 years mark, then thereon you have to do every 1 to 3 years. Every 1 to 3 years from thereon, you need to do colonoscopy. Apart from that, at any point, if the colonoscopic biopsies show presence of a cancer or a high-grade dysplasia or a mass, low-grade dysplasia are generally followed up. But if at any stage, if your colonoscopic biopsies are showing a high-grade dysplasia or a cancer or a mass, then definitely that time you need to go for surgery. You need to collect them. And finally, there are some tidbits are there. Like for example, what are the associations of IBD with fertility and pregnancy? Remember, as far as pregnancy is concerned, IBD is supposed to be quiescent disease. Like rheumatoid arthritis, this doesn't give much problem in pregnancy. At the same time, when it comes to fertility, whether the patient will get pregnant or not, it's been clearly proven that pregnancy-related outcomes are generally supposed to be bad, in the sense like, fertility-wise, there is no changes, which means patient will be fertile, not a problem, but pregnancy-related complications will be little more in patients with IBD. Like for example, there is increased risk of developing antepartum hemorrhage and prematurity, low birth weight. These are more. So what I'm talking about is the disease IBD itself becomes a little quiescent in patients with who are becoming pregnant, and but pregnancy related problems will be little more, like antepartum hemorrhage, prematurity, and low birth weight. So I don't know whether how much you understand. The IBD itself will be silent, but overall there is increased risk of pregnancy related complications like antepartum hemorrhage, prematurity, and low birth weight. Remember, active disease is always dangerous. Let it be rheumatoid arthritis, let it be SLE, let it be any autoimmune disorder. Active disease, the patient is in active disease, it's better to avoid pregnancy. So whether it has fertility implication or pregnancy implication, we don't care. But any patient with active disease, they'll be on so many drugs like immunosuppressants, and so many other problems will be there. At that time, if the patient becomes pregnant, naturally, like outcome will be bad, and the disease outcome as well as the pregnancy outcome will be bad. So we generally don't suggest the patient to go for pregnancy at all in any active form of autoimmune disease. Let it be SLE or rheumatoid arthritis or IBD, doesn't matter. So any autoimmune disease, if the patient is an active disease, try to avoid pregnancy. So don't go for pregnancy. And generally, they don't go for pregnancy usually, but better to advise them. As far as the fertility part is concerned, IBD does not affect fertility, so they will be fertile. So they don't have any problem in the sperm count or the ovum and all this stuff. When it comes to pregnancy, during pregnancy, IBD is itself gets quiescent. It doesn't give much problem, but there is increased risk of developing pregnancy-related problems like antepartum hemorrhage, prematurity, and low birth weight. So this is what is very important. But remember, there are certain medications that we use. So even though IBD as such has no change in the fertility, but certain medications that we use, for example, methotrexate and sulfasalazine, these can have an effect on fertility by reducing the sperm count. I think this is something we have discussed in rheumatology section itself. Methotrexate and sulfasalazine are very common drugs that we use in, ASA derivatives are very common drugs that we use in IBD, especially for colonic disease. We use 5-ASA derivatives. So they can basically reduce sperm count and they can cause male infertility. So infertility may be related to the drugs that we use in patients with IBD, but actually IBD has no effect on fertility. But maybe these drugs that we use in IBD may have an effect on reducing the sperm count, especially male infertility. And remember, this will be reversible in both the situations. It's a reversible male infertility. It's not going to have a permanent effect. And this is the first tidbit I want to tell: fertility and pregnancy. And second tidbit is the extraintestinal manifestations and its course with intestinal disease. Extraintestinal manifestation and its course with intestinal disease. This is the second thing I want to tell. So what are the extraintestinal manifestations that have a course that run parallel to IBD, which means dependent on IBD? There are certain extraintestinal manifestations that is dependent on underlying IBD course. And there are certain extraintestinal manifestations that are independent of the underlying IBD, which means it goes separately. It happens whether you have intestinal manifestations or not. So in that, the first one is the type 1 peripheral arthritis. So we discussed about that. Independent in the sense, it's very importantly type 2 peripheral arthritis. Type 2 peripheral arthritis is chronic in nature, and it's more of an independent. Whether you have underlying intestinal disease or not, this will go as a separate entity, which I've discussed already. Like that, erythema nodosum is dependent on underlying bowel disease activity, whereas pyoderma gangrenosum is not dependent on underlying disease activity. So that is why, when Pranavi asked me one point, like I told you, right? So initially, Pranavi is the one who put forward this question, whether doing a colectomy will have resolution of pyoderma gangrenosum or not. So actually answer is no, because this is something that is independent of underlying disease activity, which I've told you that time itself. Then apart from that, we have something called episcleritis. Episcleritis, that as a course that is parallel to underlying IBD, which means whenever you have IBD flare, episcleritis gets a flare. So, and apart from that, number 4, you have aphthous ulcerations. That also has a course that runs parallel to the underlying IBD. Because you have a flare, you get flare here also. So which means these are the things that happen in IBD as a part of underlying IBD, which means they are dependent on the underlying disease process. But like scleritis and uveitis, they don't have association with underlying intestinal disease. They don't run parallel to inflammatory bowel disease, independent of intestinal disease. And apart from that, you have sacroiliitis and ankylosing spondylitis. And apart from that, you have primary sclerosing cholangitis. So these are the things that are independent of underlying disease activity, in the sense like that are independent of underlying intestinal disease. Whether intestinal disease is there or not, they have separate course. They run separately. So you don't have any much dependence on the underlying intestinal disease. Fine. Among all the extraintestinal manifestations, only extraintestinal manifestation that doesn't have any treatment is primary sclerosing cholangitis. This is the only thing that does not have any treatment. No treatment right now. No medical treatment available. So most of the time, when you develop a primary sclerosing cholangitis, it's only more of a supportive management. So later on, if the disease becomes very severe, going for a liver transplantation. That's the only option. Clear, but more of a supportive, like stenting, because they'll have biliary strictures. You have to do stenting. UDCA is not that effective in patients with PSC. So this is the only disease that cannot be treated properly. But apart from that, most of the extraintestinal manifestations will will usually respond much to biologicals. So most of the extraintestinal manifestations have a good response to biological agents. Biologicals are the best for extraintestinal manifestations, like especially anti-TNF alpha agents. They're supposed to be best agents in patients with extraintestinal manifestations. Clear? But where biologicals will be more effective? Biologicals will be more effective for extraintestinal manifestations that run a parallel course to underlying inflammatory bowel disease, which means whatever extraintestinal manifestations that run parallel to underlying intestinal disease, which means they flare up once the intestinal disease gets flare up. Those are the ones that respond best to biologicals compared to the extraintestinal manifestation that doesn't have a parallel course to that of underlying intestinal disease. So that is also something that's very important. But almost all the external manifestations respond to biologicals like anti-TNF alpha drugs, except PSC, which does not have any treatment per se. And these biologicals will have a better response with extraintestinal manifestations that are more dependent on the underlying intestinal disease. Clear? So these are the points that you need to know. But more importantly, when it comes to your institute exams, they'll be asking you questions like this: so which is dependent, which is independent, which has better response to biologicals, which does not have treatment. So these are things that you need to know. Remember, what are independent of underlying intestinal activity is very important. Type 2 peripheral arthritis, sacroiliitis, uveitis, scleritis, ankylosing spondylitis, primary sclerosing cholangitis, and pyoderma gangrenosum. Whereas erythema nodosum, type 1 peripheral arthritis, episcleritis, and aphthous ulceration, all these things will have good correlation with the underlying intestinal disease activity. Clear? I think with this, your IBD session is over, and I think we'll close down the session today. And in the next session, we'll be discussing on the IBS, and at the same time, we'll also be discussing on the colonic polyps and colonic cancer. So I think it's only 4 days left. Today is Friday, I guess. So we'll be coming back again on next Wednesday, by Saturday, Sunday, Monday, Tuesday. I think Wednesday will come back. Thank you, and good night. See you all. Hope the session was useful. Bye-bye.